Good evening, sir. Good evening, sir.
Good evening. Am I audible?
Yes, sir.
I heard you were not well last class. How are you? What
Yes, sir.
happened?
Fine, sir. I had a miscarriage, sir.
You. Okay. Your mic is off.
Uh,
Vidhya.
Good evening, sir.
Good evening. Yeah. Just a minute. Hello? January 6. Sure. Sure. Okay, thank you. January 6 வருதான். Did Dr. Kamachi tell you anything? He has gone to conference to Patna.
Yes, sir.
So I don't know whether the recording will be possible or not. Shall we? But if you are able to communicate and hear each other, I think we can go ahead and start that.
Yes, sir.
Can you message him and ask him?
Okay, sir. So there is no reply.
He is not replying.
Yes, sir.
Okay, then we'll start. You can start presenting. You are presenting first case, no?
Yes, sir.
You go ahead and present.
Okay, sir. My case for today is 65 years chronic smoker with COPD posted for CA larynx. First, I would like to ask the identification details and the MR number. Chief complaints. My case is a case of CA larynx, so I would ask chief complaints for persistent hoarseness of voice, any signs or symptoms of dysphagia, any symptoms of odynophagia or talgia, any symptoms of hemoptysis, or any lymphadenopathy. In acute cases, the patient can present as even acute stridor. Other associated history, I would like to ask for if the patient has any cough with expectoration. If yes, I would ask for the duration, if it is continuous or intermittent, associated with sputum production, the smell of the sputum, the color, and the quantity of the sputum, if it is blood tinged or not, any postural variation, and if the cough is decreased with medication. The next, I'll ask about the history of breathlessness. If the patient is able to climb 2 flights of stairs without breathlessness, any complaints of paroxysmal nocturnal dyspnea, or also ask if there's any breathing difficulty on lying down. I would ask if whether the patient can lie down and how they have been sleeping. I'll also ask what is the comfortable position for the patient. I'll also ask for any recent loss of weight or loss of appetite, evening rise in temperature, any episodes of syncope or palpitation, chest pain, or swelling in legs. If there was any exacerbation, if yes, when was the last exacerbation? If this required any hospital admission, and if the patient was on any oxygen support or ventilator support. Coming to the past history, I will ask about the associated comorbidities like diabetes, hypertension, bronchial asthma, coronary artery disease, jaundice, and epilepsy. I will also ask about any previous surgical or anesthetic history, and I'll specifically ask for any history of radiotherapy to the neck. In personal history, I'll ask about smoking habits and the alcohol habits. In smoking, I'll ask a number of years of smoking. If the patient is still smoking, if yes, when was the last smoke? So based on this, I'll calculate the pack years on the smoking index. Coming to the drug history, if the patient is on any inhaler or oral treatment, I'll also ask for the compliance with the treatment and the duration of the treatment. Coming to the general examination, um, uh, I'll assess the conscious level, the orientation to time, place, and person, the nutritional status, the build and nourishment of the patient. I'll examine the height, weight, and calculate the BMI accordingly. I'll look for any purse lip breathing. I'll assess the vitals. Coming to the airway examination, I'll see the MPG grading. If there is any adequate mouth opening, thyromental distance, and hyomental distance. I'll also assess the neck examination. If there was any previous radiotherapy, I'll also look for the tracheal deviation, any neck masses present or not, and any previous scars present. Then I'll look for the spine examination. On on systemic examination, coming to the respiratory system, I'll on inspection, I'll see whether the trachea is in midline, the shape of the chest, probably a barrel chest. I'll look for supraclavicular hollowing, any drooping of shoulders, the use of accessory muscles in breathing, and also assess the respiratory rate. On palpation, I'll confirm all my inspectory findings. I'll assess the anteroposterior and transverse diameter. I'll assess the chest movements and the vocal phlegmatis bilaterally. On auscultation, I'll look for any wheeze or change in the breath sounds. Coming to the investigations, I'll order for a complete blood count. Here specifically, I look for anemia, which indicates a nutritional deficiency, and polycythemia because of carboxyhemoglobin may be present. On RFT, I look for serum albumin, again for nutritional status, and I'll order for ECG or echo. ECG, I look for P pulmonale or QRS amplitude in all limb leads or any presence of multifocal atrial tachycardia. And echo, I look for right ventricular dysfunction is present or not. And I look for chest X-ray. Chest X-ray, if there is any emphysematous lung changes, and order an ABG in room air. So pre-operatively, I'll optimization includes smoking cessation for at least 8 to 12 weeks as the patient is planned for an elective surgery. I'll increase the effort tolerance of the patient based on deep breathing exercise and incentive spirometry. Prevent further exacerbation by adequate use of bronchodilators and steroids. If any active infection is present, I'll treat the infection with appropriate antibiotics. I'll also optimize the nutritional status of the patient. Then coming to anesthetic management, sir.
Okay.
Okay.
Complete your presentation, then we will go for the discussion.
Okay, sir. So in investigation, I'll also order for nasoendoscopy and CT MRI because since this is a patient of CA larynx, I would also like to assess any risk of potential airway obstruction. I'll also look for vocal cord movement, the pooling of secretion, and like any narrowing or rigidity and fragility of the tissues. Then I'll also order for CT or MRI, CT with CT or MRI. Then coming to pre-op, smoking cessation, use of inhalers previous night, use of steroids previous night. If the patient is already on steroids, I'll give the NPO instructions, and any anxiolysis can be given if the patient is based on his ABG. Then my plan of anesthesia for this will depend upon the type of the surgery, sir. Here, the type of the surgery haven't been mentioned. The patient might either come for biopsy, or the patient might acutely come with an obstructed airway, or the patient might come for a microlaryngeal cancer surgery. So, based on three types, I would plan my anesthesia accordingly, sir. So, if we see for microlaryngoscopy and biopsy, if there is any non-obstructive lesion, first I'll pre-oxygenate the patient. So before that, I'll make the theater ready. Difficult airway will be ready in the theater. I'll attach all the monitors to the patient, ASA standard monitors, and then the surgeon should be available in the OT during induction, and localize the identification of the cricothyroid membrane preoperatively is essential, and uh, infiltration of the site with local anesthetics and adrenaline is essential. If we are not able to get the airway, we can take the tracheostomy with the help of the ENT surgeon. So first, when you are planning for microlaryngoscopy and biopsy, I would pre-oxygenate the patient, then IV induction followed by cuffed microlaryngeal tube with any short-acting muscle relaxant, and maintenance I'll do with 100% oxygen. Yes, sir. Then coming to a obstructed airway, that the patient comes to the emergency with stridor. For stridor, the treatment include humidified oxygen, nebulized adrenaline, IV dexamethasone, and also if heliox is available, helium 79% and oxygen 21%. Decreases the low density and increases the laminar flow. So this decreases the work of breathing. Then coming if the patient is planned for microlaryngeal cancer surgery, this is a major surgery. So first, I would pre-oxygenation. I would like to pre-oxygenate the patient. In this, I would like to insertion of prophylactic transtracheal catheter via cricothyroid membrane under local anesthesia. So I'm not. So this won't. Yeah. So this. Because this causes jet ventilation of the lungs, while the airway can be secured either by direct laryngoscopy under general anesthesia or fiber optic intubation. And it is maintained by sevoflurane or isoflurane with air and oxygen. Since this is a major surgery, I would like to take some precautions, like eyes will be padded, peripheral nerves will be protected, no pressure injuries, long ventilator tubings. As it is a shared airway procedure, I would like to have a long ventilator tubings and sampling lines, invasive arterial line based on the patient medical condition, and urinary catheterization is required as it is a longer procedure. And similarly, central venous pressure monitoring also based on the patient medical condition, and I would like to have a temperature monitoring. Maintenance can do with total intravenous anesthesia with propofol and titrated dose of propofol and short-acting opioids such as remifentanil. And so after completion of the surgery, post-operatively, I would like to admit the patient on a high dependency unit, because usually the patient is sent to the post-op with a laryngeal stoma. So I would like to admit the patient on a high dependency unit. Analgesics can be like paracetamol, and opioids like fentanyl can be given, and laryngectomy stoma care should be given.
Yes. What about tracheostomy? Do they do tracheostomy or not?
So before the procedure, the tracheostomy is usually avoided, sir.
Okay. When will the tracheostomy be done then?
Post the
Which are the
procedure.
conditions which require a tracheostomy?
So when the upper airway is total obstruction of the upper airway.
Oh, this is a cancer surgery. As you have mentioned rightly, the case scenario just says cancer surgery. It has not given a straightforward what procedure is going to be done. Okay, the procedure can be as simple as you said, from a vocal polyp or epiglottic growth cauterization to total laryngectomy, which is the most major procedure that is done for advanced cancer. Okay, so when they remove the entire larynx, what are the components of larynx?
From the vocal cord, the aryepiglottic fold, the vocal cord.
This is a basic question. Anatomy of larynx we have discussed already in our class.
Yes.
From
Anyone else,
from epiglottis to cricoid cartilage.
Yes, so it can be classified into supraglottic structures and infraglottic structures. Okay, so vocal cord forms the boundary. So structures above the vocal cord are called supraglottic structures, which include epiglottis and the hyoid bone also part of it. Even though for all description we take only the three cartilages like the cricoid and thyroid and epiglottis are considered as the cartilaginous structures. For dissection and removal, they will include the hyoid also. Okay? So if it is going to be a total laryngectomy, what is the post-op result for the patient? What are all the things he is going to lose? What is the main thing he will lose?
Voice and speech.
Voice. He cannot speak. Okay? The voice box is totally removed, so he cannot talk or he cannot speak. So this person will be. There are of course now newer techniques to, even after total laryngectomy, there are methods to make a hole in the esophagus and put a small gadget called Moyer's whistle, and then make the patient speak and train him to give a voice some similar to a normal voice also. So the important thing here, whenever a case scenario is given, even in your theory exam or in your practical exams, you always try to identify what are all the problems or challenges in this case. Okay. So first of all, the age group, which age group the patient belongs to?
65 years, elderly.
65 years comes under what group?
Elderly.
Geriatric age group. Anybody above 60 is considered as geriatric. So all the challenges of geriatric anesthesia is very common in this patient. You have to anticipate that. Okay, all the changes. So whether the patient has, what is the difference between chronological and physiological age? What is the difference between chronological and physiological? Is there anything called these two ages are there, chronological and physiological?
Physical is according to the age, the number
Of years of age. Okay, so this patient chronologically is 65, but physiologically he may be more fit if he does not have all these comorbidities and cancer. Any patient coming for surgery may be looking much younger with a heart rate of say 75 to 80 and BP of 110/70, weight within normal limits, agility and movement, effort tolerance. These are all very good for the patient. That may be counted as a normal, less than, more physiological and younger for his age. On the contrary, a patient at 65 with arthritis, already having some coronary artery disease or COPD like this, not able to do his normal, so they age faster and have lesser fitness and lesser effort tolerance. Okay, so we must always see whether the patient's chronological age and physiological age are matching, or whether he is more fitter by physiological age or more older by physiological age, by all the systems getting affected more than the normal for his age. So that is the first and foremost thing we have to assess in that patient. And the second problem here is he has been having COPD. So this COPD should have been happening even before they diagnose cancer in this patient, because the cancer larynx does not produce COPD as a consequence or sequence of the cancer. Okay, so COPD must have been present in this patient, and on top of it, he smokes also with the COPD. So you must take a detailed history about his COPD, how many number of years he has been suffering, whether there has been any exacerbations which require ICU admission or ventilatory support. So all that we have discussed in our class on COPD management. All the mnemonic I have given you earlier, how to CCAN is the mnemonic that we have to find out. And then any present infections, superadded infections are there. And all the consequences of chronic smoking, as you said, how many number of pack years, how much he has been smoking, is he still smoking, does he have a smoker's cough? So that part will be the first challenge in this patient. The second thing will be he is having CA larynx, which extent and the location of the cancer we do not know, because larynx extends from epiglottis to tracheoid before the start of the tracheal rings. The entire structure is called larynx. So it may be anywhere in that area, and the extent and the spread of the disease to other areas like the lymph nodes in the neck, we do not know any of those things. So it may be a very minor surgery, as you said, with a microscope laryngeal excision of a small tumor in the vocal cord or anywhere adjacent to the vocal cord, or it may be a hemilaryngectomy or a partial laryngectomy or a total laryngectomy, which is the ultimate maximum extent of surgery that may go on. And here for that, the peculiarity for this is there are two types of anesthesia, tube anesthesia and tubeless anesthesia, which is also called closed and open airway surgeries or anesthesia. Okay, what is the difference between closed and the open anesthesia? Closed airway and open airway anesthesia. How will you administer that? Have you had any chance to see a case of CA larynx in your posting so far?
Not CA larynx, sir, but they have come with an obstructed airway for which
a
yes,
polyp
sir.
obstructing the vocal cords and coming pendulous
Yes,
polyp suddenly obstructing the vocal cords. Okay.
Yes, sir.
So whenever you say a closed airway, that means there is a endotracheal tube of some size is present in the trachea. That is called closed airway, which segregates the airway from the lower respiratory tract. Okay, you are preventing aspiration because there will be a cuff which will prevent any secretions or blood from the upper airway going down in the lung. Whereas in an open airway technique, what you do is you use either a high flow oxygen or a jet ventilation or high frequency oscillation ventilation, which are all administered either through the vocal cords or through, as you said, through the cricothyroid membrane by the high flow of high respiratory rate and flow of oxygen, which traverses because of the mass movement and oxygenates the patient. Okay, that is called open airway technique. And the chances of aspiration are more in open airway technique, but that may be required for more clearance, surgical clearance of the tumor. So whenever surgeon wants to do an extensive resection and clearance of the tumor, the anesthesia technique of choice will be an open airway technique, okay, which we will see just now. And you said you will infiltrate the cricothyroid membrane with lignocaine and adrenaline. Is it required to infiltrate it with adrenaline? Does cricothyroid membrane have a rich blood supply?
No, sir, it's a bloodless.
It is a bloodless membrane. So there is no need for adrenaline to be infiltrated into that. And if it is going to be done awake, then you require lignocaine infiltration because the skin will be painful. Otherwise, you have to, under anesthesia, you can just nick it and then put a catheter inside and keep that for jet ventilation. And then, so as you said, nowadays, even for total laryngectomy, they always, the surgical preference is to first achieve an intubation. And then as the surgery is proceeding, after all the external dissection is done, and when the neck is, the mass is going to be removed head block, that is the time they create a stoma, either a laryngeal stoma or a tracheostomy stoma. And then you introduce, you withdraw the endotracheal tube above that stoma, introduce a special type of tube to continue anesthesia with that stoma. What are the tubes that are required for continuing the inhalation anesthesia, either through a laryngeal stoma or a tracheostomy stoma? That also has to be mentioned in your, or maybe asked in the examination also. Okay, are there special tubes which they use for intraoperative use for continuation of inhalation anesthesia after creating a tracheostomy or a laryngostomy? Have you heard of J tube or laryngeal tube, Montandon's tube?
Yes, sir.
So they are all the tubes that can be used, and so that also has to be. What about blood loss in this surgery? You mentioned that it may be a long surgery, it may require temperature monitoring, it may require neuromuscular monitoring, all these things you said. What about blood loss? Which condition will have more blood loss? Which surgery, which type of surgery will require cause more blood loss? A total laryngectomy with a neck dissection, will it cause more blood loss, or just a polypectomy will cause a more blood loss? More the dissection, more the blood loss, especially if they have secondary nodes and they plan for a neck dissection along with the removal of the cancerous tumor, then it may cause more blood loss, and you have to be prepared to manage that blood loss and manage to maintain the hemodynamic status of the patient. Okay. So otherwise, you have covered more or less all the points. Only thing what you require to know is in the exam, they may ask you about the different types of surgery and the different techniques of anesthesia. And TIVA plays a very main role in this, especially when you do tubeless anesthesia or open anesthesia. Total intravenous anesthesia will be the most useful technique to maintain. Of course, you mentioned about it using propofol and remifentanil. Use of dexmedetomidine and ketamine are also being practiced in this context. And so the oxygenation can be very well achieved with 100% oxygen when you give PIVA rather than going in for inhalation induction, which may cause desaturation because of the other problems that you have. So I'll just share the screen with you to show how to approach this problem. Are you able to see the slide?
Yes, sir.
Okay. So this is the case scenario, 65-year-old chronic smoker with COPD posted for CA larynx surgery. And so challenges in this case can be classified as 65 years old geriatric age group with the problems inherent to the geriatric age group patients. They namely the chronological versus biological age. How fit or how worse the patient is for his age. The second thing is chronic smoking effects with various systems and whether the smoking was the cause for CA larynx. Chronic smoking itself can be the positive factor for CA larynx, and patient may have COPD even prior to the cancer occurring in this patient, and how whether it is mild, moderate or severe, and what is the respiratory insufficiency caused by the COPD is the next point. And fourthly, surgical procedure planned and adaptations required for the particular surgical procedure and how much of duration it will take. So these are the four challenges that you have to face in this case. The preoperative assessment, you have to first assess the medical comorbidities, especially how well controlled the COPD is, what is his effort tolerance, what is the response to the drug therapy, especially inhalers or nebulizers, and how much of breath holding he can do, and how frequently he gets attack of COPD, how serious it is. All that has to be totally assessed, and whether the chronic COPD has produced a strain on the right heart by all the investigations and other clinical findings. You have to make sure that the right heart function is also normal. Normally, we look into only the left heart function by ejection fraction and fractional shortening and all those things. But here we have to give more attention to right heart functioning by looking at the right ventricular ejection fraction as well as the pulmonary pressures. Okay. Then dyspnea, whether the patient had dyspnea even before the onset of cancer because of COPD, or whether it is because of the airway obstruction caused by the cancer, which is causing the problem, which can be differentiated using the flow volume loops, which will be the only thing that is required from pulmonary function test in these patients. An arterial blood gas analysis is very useful in this patient to ascertain the gas exchange problems and whether they may have to be supported by ventilatory support in the post-operative management. So this is one of the important investigations you have to keep in mind. And what are all the drugs patient has been taking, like preoperative steroids, bronchodilators, and advocate smoking cessation. If you have time for the surgery, if it is done as an elective procedure, you always have time to optimize the patient by asking him to stop the smoking. And chest physiotherapy can be instituted to clear any secretions and make him more fit for the surgery. Then laryngeal cancer itself may impede airway management with a mass effect or because of local inflammation or edema following radiation or fibrosis, as well as scarring from a prior surgery. Sometimes it is done as a 2-sitting or 3-sitting or stage surgeries may be done. So in that case, the previous surgery scarring also may contribute to the airway obstruction. And preoperative discussion of airway management with regard to device selection, that is whether you are going to do intubation technique or not, what is the ventilatory strategy, whether neuromuscular blockade is required or not. And if it is a laser procedure, I think you have not mentioned anything about that. Nowadays, they do resection of the laryngeal tumors using laser to prevent unnecessary blood loss. And if it is going to be done as a laser procedure, the risk of fire is always there. And the table orientation, because the surgeon and his assistants, all of them will be swarming around the head and neck of the patient. Your approach to the patient will be from the foot end only. Okay, so you have to get oriented to giving anesthesia, because majority of the times you are always oriented to standing by the head end of the patient. So you may find it odd to stand at the foot end and administer anesthesia. So that also you should keep in mind. And the type of surgeries that can be done are laryngectomy, which can be total, partial, or hemilaryngectomy, or it may be removal of the vocal cords alone. If it involves the growth involves the cords, then it's called cordectomy. Then it can be endoscopic laser surgery. And nowadays there are robot-assisted surgeries are also done, and neck dissection is done, and tracheostomy is part of a total laryngectomy procedure. So these are all the things that you have to be aware of in this particular surgery. Now coming to the airway assessment, glottic cancers are the commonest and present early with cardinal symptoms like hoarseness. Patient will be coming with a complaint of change in the voice. And hoarseness may be sometimes very late symptom in any supraglottic tumors. So if it is in the vocal cord level, that is the glottic cancer, then hoarseness will be the early sign or clinical complaint. Whereas the hoarseness may be very late when the tumor is in the above the glottis. And other common presenting symptoms are, as I said, dysphagia, odontophagia, cough, pain, etc. And positional exacerbation of airway symptoms, often because of supraglottic or pedunculated glottic tumors, which can suddenly obstruct the airway and produce a difficulty in breathing. But when the patient is upright and the laryngeal tone is intact, this may not be very obvious. But once you make the patient lie down and anesthetize him and relax him, and the pharyngeal tone is lost, then these supraglottic pedunculated tumors may obstruct the vocal cords completely and prevent you from ventilating as well as intubating the patient. So that is where your nasoendoscopy will be very, very useful in identifying where exactly the tumor is and what could be your plan of anesthesia well in advance before you anesthetize the patient. And patients may present with sleep disturbance, and they may have snoring because of the upper airway tumor or the cyst. And a history of waking up at night with panic, just like a OSA patient who gets obstructed and wakes up with a panic with inability to breathe, that also may suggest there is a critical obstruction in this patient. And dyspnea and stridor due to airway obstruction may happen if the disease becomes very advanced and the cancer spreads to the entire larynx. And the assessment of airway should include an assessment of mouth opening also, especially if the patient had a course of radiotherapy to decrease the mass size before surgery. Then you have to make sure that mouth opening is not restricted because of the fibrosis or inflammation in the muscles around the neck and jaw, which may cause decreased mouth opening, and the Malambati score also get modified. A laryngoscopy view at the previous operation. Whenever a patient comes with a recurrence or in a staged procedure, it is better to go through the notes to find out what was the finding in the previous surgical anesthetic notes to see the amount of mouth opening, the ease of intubation, the neck movement, etc. can be got from the earlier notes. Then you have to make an examination of the neck structures for mass, scarring from previous surgery, or whether immobility of the larynx from previous radiotherapy is all added information that you require. A preoperative nasoendoscopy is essential. It will give you airway diameter, location of the tumor, size of the tumor, nature and mobility of the tumor, whether vocal cords are functioning or already paralyzed on one side or partially on the other side, and pooling of secretions whether present. Importantly, the risk of potential airway obstruction. All these findings can be done. So this is one of the important preoperative or pre-anesthetic assessment should be include apart from the other investigations that we routinely do for any surgical case. Preoperative nasoendoscopy is very essential, and you have to go through all the radiographic images, especially CT, MRI, and chest X-ray, defining the primary site and assess extralaryngeal and nodal spread of the disease. And CT images may give a 3D constructed images of the lesion, providing accurate anatomical information. And this will help you to know whether you will be able to intubate the trachea easily or not, or you may have an idea about endoscopic analysis also if you are planning a fiber optic intubation. Now, coming to the types of surgery which can be done for CA larynx, microlaryngeal surgery for small lesion. The airway management options can be broadly classified into closed and open methods. This is where I told you, if you put a tube in the trachea, it becomes closed. It segregates the airway from upper and lower sections, whereas in open, it is open to all the tracking down of not only the gases, but other things also to the lower respiratory passages. For non-obstructing lesions, closed system offers lower airway protection from soiling and allows greater ease of ventilation with minimal environmental pollution, because you will be using a cupped endotracheal tube of a smaller size. But the main disadvantage of this closed system of ventilation is poor surgical access. Surgeon may not be able to excise the tumor in toto because the tube is present, or sometimes they will complete the surgery as much as possible and in the last minute ask you to remove the tube and go ahead with jet ventilation so that the rest of the tumor also can be removed. So that is the only disadvantage with this particular technique. And laser resistant flexometallic tube should be used if you are planning for the small resections can be done using laser surgery here. So in that case, you have to go for a laser resistant flexometallic tube. Whereas an open system of management allows improved surgical access because there is no tube. The surgeon can see the entire cancerous mass and do a good resection using this particular system. And for open, various systems have been described, including spontaneous ventilation with the insufflation of air and oxygen, oxygen and gases, jet ventilation, intermittent apnea, and negative pressure ventilation. So these are all the modifications of ventilation that should be planned for open system of anesthesia, airway management. Now coming to the major laryngeal cancer surgery, the principles are the selection of anesthetic induction technique and airway management for major surgery are similar to microlaryngeal procedures. That is, the same closed or open method can be practiced. And insertion of a prophylactic transtracheal catheter via cricothyroid membrane under local anesthesia allows high frequency jet ventilation. That is, this point you have to clearly understand. If you plan for a combination of closed and open method, what you have to do is first you have to put a transtracheal catheter via cricothyroid membrane, but don't use it at the beginning of surgery. Rather, you do a conventional scopy or a fiber optic scopy and insert a endotracheal tube to proceed with the surgery and avoid the need for primary tracheostomy in this case. Once the surgeon has completed the dissection and is going to remove the larynx, you remove the endotracheal tube and continue the ventilation through this tracheal catheter. So that is what the present day requirement for major laryngeal surgery. So the requirements or the steps in this surgery are the patient is usually positioned with a head up tilt so that venous drainage will be adequate and the venous congestion and pooling and excess bleeding cannot happen, but it has the risk of venous air embolism. And the patient's eye and eyes must be padded and protected properly, and all the peripheral nerves where compression or pressure points are there to be properly padded to prevent any damage to the nerves. The third step is the anesthetist is removed from the head end. That is where the earlier slide I showed you orientation to the table. So the anesthetist is removed from the head end of the operating table, and consideration will be given to long ventilator tubing, sampling lines, and appropriate monitoring equipment. So preferably you can go for a IV line on the foot or the dorsum of the foot or the ankle, so that the access will be much more easier for administration of either TIVA or your if you are going to give intermittent bolus doses. Everything can be easily achieved by an IV line in the lower limb rather than in the upper limb in these cases. In addition to standard non-invasive monitoring, if it is a major laryngeal resection like total laryngectomy, it is better to have an arc line and a urinary picture. The CVP line will be determined only by the extent of surgery and the cardiovascular status of the patient. And the CVP line you cannot do like your regular IJV because sometimes it may involve the neck dissection also. So the central line is usually through the antecubital or a femoral vein. That is the route of insertion of CVP line. That is the difference between a regular CVP monitoring in other cases and this case. And the ventilator tubing and vascular access lines, they will all be covered by the drapes. So before you start anesthesia and hand over the patient to the surgeon, make sure that all the connections are securely connected and firm without chances of disconnection. And laryngeal surgery, when combined with radical neck dissection, can take many hours. So better to use humidifier, warmed intravenous fluid, and post-air warming devices with temperature monitoring to maintain normothermia of the patient. And maintenance of anesthesia may be provided by volatile anesthetic agents or TIVA. So TIVA is most commonly preferred technique, especially if you are going to do open technique, as I said earlier. And remifentanil combined with sevoflurane shown to maintain cardiovascular stability, rapid and full emergence during microlaryngeal surgery. And the attenuation of cardiovascular responses like bradycardia or tachycardia, hypertension, etc., because of the manipulation of the larynx is very, very important, and you have to be very watchful and treat it accordingly. The baroreceptor stimulation occurring during surgery and coronary artery spasm provoked by carotid sinus stimulation, especially during extensive neck dissection, where they pull the carotid artery and bifurcation and all that. That may cause this baroreceptor stimulation, which has to be managed. Blood loss is often hidden under the drapes and may not become apparent until the end of the surgery. So always be prepared with adequate replacement of blood in extensive neck dissection combined with laryngeal excision. And particular risk of endolaryngeal laser surgery is the potential for airway fire. So if laser is going to be used, then it is always all the precautions of laser surgery have to be followed and to avoid any airway fire occurring because of that. And laryngectomy without a stoma is a modern method of doing it to preserve some speech function in these patients. So not requiring an end stoma, to be the extubation should be carefully done if they don't have a laryngeal stoma or a tracheostomy and partial resection is done. Then extubation has to be planned well because they can go for post-operative airway obstruction. And the causes of that is swelling of the soft tissues after prolonged surgery, or bleeding or airway debris making the extubation hazardous. So if initial tracheal intubation done in these cases itself is very difficult, and re-intubation after there is a swelling, bleeding, etc., will be much more cumbersome and difficult. So it is always better to use a airway exchanger catheter in these cases before you plan the extubation, so that you can railroad and re-intubate the patient in patients who do not have a stoma after laryngectomy. And supraglottic laryngectomy offers the advantage of complete cure of resection of the cancerous tissue, preservation of speech for certain types of tumor, and only a temporary tracheostomy may be considered for some time in the immediate postoperative period. And what are the precautions one has to take for postoperative care of the patients after CA larynx surgery is specially trained staff who are capable of managing tracheostomies or airway emergencies should be posted in that particular ward, or it must be a high dependency ward. Analgesic requirements can be met with IV morphine, PCA, or supplemented with paracetamol and non-steroidal anti-inflammatory drugs. And careful management of the tracheostomy is necessary in the immediate post-op period with humidified oxygen, and also frequent suctioning to keep the stoma or opening clear. And patients should be kept in semi-erect position, reclining position of head up tilt of 20 to 30 degrees, which will improve venous drainage, reduce the swelling, and improve respiratory mechanics also. And proper attention to fluid balance and nutritional requirements by early enteral feeding. So if you see a patient with total laryngectomy, first thing they will do is put a nasogastric tube and then only start the surgery, so that this can be used for early enteral feeding in the postoperative period. Sometimes you may need to put what is called the PEG, percutaneous endoscopic gastrostomy, has to be done for long-term cases where putting an NG tube is contraindicated. Then you can go for a PEG for taking care of the nutrition of this patient. And managing a stridulous emergency, what Sanjutha has seen already, their high flow nasal oxygen has been brought to the forefront of the airway management. And Thrive machine is also used nowadays because it not only causes oxygenation but also helps in elimination of carbon dioxide. That is the advantage of Thrive, and that is why it is called ventilator exchange. It is not just called oxygenation, but it is called ventilator exchange because it not only makes the oxygenation possible, but for up to some particular time. It cannot endlessly do the elimination of carbon dioxide, but up to, they say, 30 to 40 minutes of Thrive will definitely maintain PCO2 also within the acceptable level. Then pre-induction management of these patients with stridor because of a pedunculated tumor. The acronym that you can remember is CASH, and the C stands for continuous positive airway pressure, which can be provided with HF involved itself, that is high flow nasal oxygen itself will give a CPAP effect. Then nebulized adrenaline will also reduce the stridor by reducing the vocal cord edema. Steroids also will help, and Heliox. So these four first letters are made into an acronym called CASH for the management of a stridorless emergency stridor patient. And medial laryngoscopes are considered the common first choice gadget for laryngoscopy instead of our conventional Macintosh or Miller blades. And these are all the various types of cancerous growths that can be seen in your laryngoscopic view. And awake fiber optic intubation is not preferred technique in patient with a critically narrowed laryngeal infect. So especially if the patient has a very narrow laryngeal inlet or a glottic opening because of the growth, fiber optic intubation in such cases will completely obstruct the airway. There will not be any gap between the fibroscope and the trachea, so it will cause a total obstruction, and that may result in a complete inability to ventilate the patient. So this is the picture that you will see with a very, very narrow glottic opening. So in this sort of, this can be identified by your nasal endoscopy or nasoendoscopy. So in such cases, the AFOA, that is awake fiberoptic intubation, has to be avoided. And it is, but it is extremely helpful in all supraglottic airway obstructions. That will be the indication for that. And so this is the picture how you will see for a supra airway glottic zone. Okay, so that will be the points that I would like to share with you for this particular topic. So the surgery can be a simple microlaryngeal excision or a partial excision with without a laryngostomy or a tracheostomy, or total excision with a tracheostomy, which is usually done in the beginning and then anesthesia proceeded in the earlier days. But current day practice is to go ahead with the intubation technique, where is the close technique, do all the dissection, and before removing the laryngeal growth and with the entire in toto, you pull out the tube and ventilate the patient through the tracheothyroid catheter. And at the end, if requiring, you may do a tracheostomy hole also and maintain the post-op ventilation through that. Okay? So these are the three types of management that you have to know about. Of course, this is a very advanced method for usually done in cancer institutes and other things. In other institutions, this sort of surgeries are not performed very frequently. But in the exam nowadays, they are all keeping different cases, especially in practical exams. They are keeping, if you unfortunately happen to go to an institution, onco institutions for your exam, then this sort of cases may be kept. So instead of repeatedly discussing about cirrhosis liver, CKD patient for transplant, liver transplant, COPD, and all those common topics which we have already discussed, I thought of discussing some of the rarer cases during the before your exams, so that in case you are suddenly caught unaware of a case like this, I thought you should have some amount of knowledge to manage those cases. Okay, so that is the idea of giving these rare cases for you. So I would like to get your feedback whether it is okay with you or whether we should go to conventional grinding the same dough again and again. Okay, we will decide later. So shall we? Any doubts or any questions on this?
Sir, how will be the ventilation strategy since we have a COPD patient and a long procedure?
Yes, that depends on the severity of COPD. How, that's why I told you that you must take a very detailed history of how severe the COPD is, how many times a year or how frequently patient gets hospitalized with severe dyspnea, whether he has to be admitted in ICU, whether he has had any ventilatory support. And by making his assessment of his pulmonary function test like FEV1 and FEC ratio, which will give you an idea about whether it is a mild, moderate, or severe COPD. You have to go for the plan your ventilatory strategies according to that. Okay, and both closed as well as open ventilation strategies have the advantages as well as disadvantages in these patients. The advantage of tubeless or the open system is there is no irritation of the already irritable airway in these patients because you are not putting any tube. But at the same time, these COPD patients may have an emphysematous bullae or anything, and the possibility of a rupture and producing a pneumothorax is also very high. So you have to judiciously adjust your pressure and try to do a ventilation using the same conventional low tidal volume, increased frequency rate with the expiratory ratio longer than the inspiratory ratio, because COPD elimination of CO2 is more
Okay.
important than oxygenation. So that strategy has to be followed. Okay.
Okay, sir.
Will we go to the next topic? Who is presenting the next one?
Sir, myself, sir, CTEV question, sir. Yes, sir.
You done a CTEV
My
surgery, Shobika?
we have put casting, sir.
You have done only
Cast.
casting, not
Yes,
the
sir.
corrective
Not the
surgery.
surgery.
Okay.
Yes,
Okay,
sir.
right. Okay, go ahead.
Yes, sir. Yes, sir. 9 months old male child posted for a CTEV correction. First, I'll ask for history, sir. History of presenting illness. When was the deformity noted? And when was the diagnosis made? If the deformity is progressive or non-progressive. And I'll ask if there is any history of associated complaints like recent fever or respiratory tract infections or recurrent respiratory tract infections. And then past medical history. I'll ask about any associated comorbidities like history of neurological abnormalities, congenital heart disease, bronchial asthma, if there is any history of muscular dystrophy. And I'll also ask about any history of current drug intake. And in the past surgical, I'll ask about the attempt of any deformity corrections, like any previous serial casting done or any surgical procedure done. And then coming to antenatal history, I'll ask about if the conception is natural or artificial, if all the 3 trimesters were uneventful, if there is any history of oligohydramnios in the mother, if there is any prolonged history of maternal drug intake, if there was any history of antenatal smoking or alcohol intake. Coming to birth history, I'll ask about if it is a term birth or preterm birth, and if it's a normal vaginal delivery or lower segment cesarean section, and birth weight of the child, if the baby cried immediately after birth, or if there is any history of asphyxia, cyanosis, or breathing difficulty, and if there is any history of NSU admission. In family history, I'll ask whether it's a consanguineous or non-consanguineous marriage, if there is any similar deformity history in the family. Coming to developmental history, I'll ask whether all the developmental milestones has been achieved according to the age of the child. Nutritional history, if there is if the feeding is regular and the weight gain is appropriate for the age, and immunization history, if vaccination is done up to date. In allergic history, I'll ask if there is any food or drug allergy in the child. Coming to general examination, I'll check if the child is alert, active, and febrile. I'll look for pala cyanosis, clubbing, lymphadenopathy, and also look for spine or hip abnormality. And I'll measure the height and weight of the child. And I'll measure the vitals, that is saturation, respiratory rate, and heart rate. And I'll assess the IV axis, and also in airway, when the baby is made to cry, I'll look for mouth opening if the uvula is visible or not. And coming to systemic examination, in cardiovascular, I'll look for heart sounds, and if there is any murmurs. In respiratory system, I'll auscultate and look for any added sounds. In GI, I'll look for bubble sounds, and if there is any associated organomegaly. In local examination, I'll look for the range of movement of the foot, and if there is any deformity like forefoot adduction, if the heel is elevated, the midfoot is high arched, and if the hind foot is pointed downwards. And then coming to investigations, I'll ask for complete blood count, blood grouping and typing, and echo to rule out congenital cardiac defects. So anesthetic challenges in this case is pediatric patient with a small age group, difficult venous access and airway management, starvation, and parental separation anxiety. Preoperative preparation, I'll get the child's parents concerned. I'll explain about the plan of anesthesia, and I'll also explain about the fasting guidelines, which is 2 hours for clear liquids, 4 hours for breast milk, 6 hours for non-human milk or infant formula or light meal. And I like to pre-medicate the child to reduce the parental separation anxiety with the oral midazolam 0.5 mg per kg, which will be given 30 to 60 minutes before surgery. And intraoperatively, I'll make sure anesthetic workstation is checked. All the appropriate size airway equipments were kept ready, and anesthetic drugs and emergency drugs are loaded according to the weight of the child. In monitoring, standard ASA monitoring, ECG, pulse oximeter, NIBP, temperature, ETCO2, and precordial stethoscope in this case. My plan of anesthesia will be depend on the type of the surgical procedure. If it is casting or tenotomy, It can be done under general anesthesia with face mask using volatile sevoflurane with spontaneous ventilation, or we can do local infiltration with sedation using IM or IV ketamine. If it is a soft tissue release or bony reconstruction, GA with caudal epidural or GA with popliteal nerve block can be done. The procedure can be done in supine, lateral, or prone position. If the procedure is less than 90 minutes and it is done in supine position, I'll go for GA with LMA of size 1.5 for this child. If the procedure is greater than 90 minutes and it is done in prone position, I'll go for GA with the endotracheal tube of size 4. And maintenance of anesthesia, I'll use sevoflurane, fentanyl 2 mics per kg, and short-acting neuromuscular blockade like atracurium or cisatracurium. My choice of fluid in this patient would be isotonic fluid, either 0.9% NaCl or oral. Once the airway is secured, if it is a soft tissue release or bony reconstruction procedure, I'll put the child in a lateral position for the caudal block. My choice of drug would be 0.25% bupivacaine. The dosage required is based on the green Armitage formula. For sacrum dermatome, it is 0.5 ml per kg. For lumbar, it is 1 ml per kg. For mid-thoracic, 1.25 ml per kg. And other modes of analgesia, use IV or parectal paracetamol suppository, just 15 to 20 mg per kg. Or we can use diclofenac, 1 to 2 mg per kg. We can also for the extubation, when the child is fully awake and the child is hemodynamically stable and there is return of adequate spontaneous ventilation. Post-operatively, I'll monitor the vitals, I'll provide adequate analgesia and then good hydration, sir. That's all, sir.
Very good. Excellent. So this is a classical case of CTEV. We do not, again, in this case, it is just given correction. So we do not know whether it is a tenotomy or whether it is going to be a soft tissue release and bony alignment surgery. So based on that, you can give all these problems. What is Pirani score? Are you aware of
Pirani score? Yes, sir. The scoring system done to find out what type of surgical correction to be done. There are 5 scores, sir, depending on the creases and heel present or absent. All that.
So that is the one which will tell you about the severity and the extent of repair that is required. Okay? So you must have some idea about that. So the suddenly examiner may ask you what is Pirani score and how do you decide the treatment part of that. Of course, this is mostly by the orthopedic surgeons or the pediatric surgeons who handle this sort of patients. So we have covered almost all the points. So I'll just go to share the screen with you and
yes, sir.
I hope it is visible. So this is a 9-month-old baby. So the challenges are, the first challenge is a pediatric, especially it's an infant. So anesthesia with its inherent challenges of pediatric anesthesia. So the questions, instead of being asked about the anesthetic technique for CTEV, you must be prepared to answer all the questions comparing the pediatric airway with adult airway, the differences in cardiovascular system, respiratory system, and other systems, temperature regulation, all those things you must be thoroughly able to understand with regard to pediatric anesthesia. The second problem is it's a congenital defect where surgical intervention is required. So look for any possibility of other congenital anomalies, especially in the cardiovascular system. They may have associated cardiovascular congenital anomalies. So always in any congenital system, mention this point of ruling out other associated congenital defects in the other systems of the patient. And management of post-op pain in infant may be difficult because assessment of pain in pediatric patients, especially children who cannot vocalize or verbally give their opinion, is very difficult to assess the severity of pediatric pain. And so that also is a challenge to manage the post-op period. Now the Pirani score, it has a score clinical examination to assess the 6 features of the baby's foot, 3 in the midfoot and 3 in the hindfoot. So that is what this scoring system does. Each feature is scored as a scale of 0 means no deformity, 0.5 means moderate deformity, and 1 means severe deformity. And a total score will be 3 for the midfoot and 3 for the hindfoot. On the worst case, each one will go to 6 is the total maximum number you get. So the higher the score, it indicates severe clubfoot. Lower the score indicates less severe the clubfoot. So this will decide whether it can be managed by repeated casting with plaster of Paris, or whether it has to be operated by a tenotomy, or whether it has to be done with a full tissue correction, soft tissue release. So the Pirani score is used to monitor the progress, determine whether to perform a tenotomy, and predict the number of casts that are required. So higher the score, even to correct with the repeated casting, it may require at least 4 casts at intervals up to a month or so as the child is growing. And a score of less than 4 requires less than 3 or lesser than 3 casting to be done. So that is the advantage of doing that. And this picture will give you an idea about the midfoot contracture score. There will be a mild crease, medial crease. You can see in this case 0, the crease is not there. The foot is almost normal. Here you can find a small crease, and here you can find a very severe crease. Okay, that's a medial crease. Then curved lateral border of the foot. So here it is almost straight. Here slight bending, and you can see this is the severely curved lateral border. And lateral head of talus, that is you can press it and see this is how the whole thing, especially in the X-ray, you can see the talus rotation. And with regard to the hind foot contractures, similar to medial crease, there is a posterior crease, and you can see very normal, slightly bent and more severe, empty heel, and there is no 0.5 score in this. Here it is only 0 and 1. And with regard to rigid equine, there is again 0.5 and 1, and that is by the angle formed by the lower end of the leg with the axis of the lower end of the leg with the axis of the foot. So that is how the whole thing. So here it is, you can do a flexion and get a acute angle. Here it is almost like a light angle. Here it becomes an obtuse angle in a very severe case. So that is the equine deformity that is happening. So the anesthesia for various surgical procedures to correct a clubfoot, as she rightly said, percutaneous stenotomy, which can be done with LA infiltration and with IM or IV sedation with ketamine, or you can hold a mask with oxygen, air, and sevoflurane, and maintain spontaneous respiration. And after infiltration of the local, it is not going to cause any pain. So it needs just a quiet patient. So that can be achieved by these two techniques. And so this is the picture of how do you anesthetize with the inhalation agent. And for an older child, you allow him to watch the video games in his phone, and then you, without disturbing him, you can hold the mask above the face and anesthetize the child. And here is another child using his tablet and watching, and you know, how much of care is being given those countries to prevent the mental trauma to the pediatric patient, especially when they do inhalation induction. They don't want the child to cry with the fear and get a mental trauma, to get scared about anesthesia and surgery. So this is the technique that they follow by making the child get diverted with some games of their choice. Coming to TA lengthening, this is a more extensive procedure which may require a sedation, and caudal block can be more than enough, or it can be done under sedation and popliteal block also. So this is the usual picture of caudal block. All of you are aware. This is the sacral hiatus, and this is the posterior superior iliac spine prominence, and the lateral popliteal nerve block can be done using the nerve stimulator, and you can block that nerve alone selectively. And extensive tissue and the ligament release can be done with either GA with LMA or ET tube or a caudal and a nerve block combination. So if you do that, you can even if it is going to be in the supine position, after a successful caudal block, can do it just quieten the child with a mask ventilation, spontaneous breathing with a inhalation induction. And she rightly said, if the position is going to be turned to lateral or supine, then maybe better to go for a endotracheal intubation to have a secure airway rather than risk the patient with LMA. Whereas in the supine position, either a mask ventilation with a spontaneous breathing or an LMA insertion with a spontaneous breathing with a successful caudal block or a nerve block is more than enough. Okay, so these are all the things that we have to keep in mind with regard to this particular surgery. Okay, so that's a short case scenario.
Yes, sir.
So you may be directly asked about the diagnosis and what are all the interventions that are done, and whatever answers you are given are absolutely correct for that particular case scenario. Okay.
Yes, sir.
Who is presenting the next one?
Sir, I will be presenting, sir.
No, go ahead.
So, obese patient for functional endoscopic sinus surgery, sir. So, obesity is defined as abnormally high amount of adipose tissue when compared with the lean muscle mass. It is classified with the help of BMI into underweight, normal, overweight, class 1, 2, 3 obesity. And we have to know about the ideal body weight, lean body mass, and the actual body weight. Coming to the history, history pertaining to the surgery, like whether the patient has any present symptoms of cough, cold, any abnormal breath sounds, purulent nasal discharge, and history suggestive of systemic diseases which could be associated with obesity, like coronary artery disease, diabetes mellitus, systemic hypertension, dyslipidemia, obstructive sleep apnea with the help of stop back questionnaire, and any history of GERD, history, other medical history and medication histories, history of smoking and alcohol. And we have to assess the functional capacity with the help of history and also by assessing the patient with 6-minute walk test or stair climbing test. On examination, we have to calculate the BMI. We have to document the baseline vitals. In case of systemic hypertension, the baseline BP, and in case of COPD or obstructive sleep apnea, baseline saturation, respiratory rate, and pulse rate. Airway examination, which includes Mallampati grading, neck movement, thyromental sternomental distance, mandibular protrusion, and dentition. Systemic examination, which could be suggestive of any cardiac and respiratory illness. We have to assess for any abnormal rhythm or abnormal heart sounds. We have to look for abnormal sounds or added sounds in the respiratory system. Then preoperatively, I would ask for complete blood count to look for polycythemia in case of prolonged hypoxia, renal function test, liver function test, coagulation profile, and blood sugar profile like fasting postprandial blood sugar and HbA1c, lipid profile, ECG and echo to look for any cardiac abnormality like abnormal rhythm, any biventricular failure, and look for any ventricular hypertrophy, pulmonary artery hypertension. And I would like to ask for arterial blood gas analysis, pulmonary function test, and polysomnography based on the status of the patient. And the anesthetic consideration in an obese patient for functional endoscopic sinus surgery is comorbidities like obstructive sleep apnea, obesity, hypoventilation syndrome, and restrictive lung disease. In CVS, systemic hypertension, coronary artery disease, a patient may have a biventricular failure, pulmonary hypertension, hypertriglyceridemia, and they could have sudden death and conduction abnormalities. And they have poor lung reserve, poor functional capacity. There could be associated metabolic syndrome, which consists of central obesity, systemic hypertension, impaired glucose tolerance, increased triglycerides. and also with non-alcoholic steatohepatitis and non-alcoholic fatty liver disease. Other implications are they have increased sensitivity to sedative hypnotics and opioids. They have increased risk of apnea and airway obstruction perioperatively. There is a difficulty in maintaining airway and difficulty in ventilating the obese patient. They require higher minute ventilation to achieve normocapnia. They have poor chest wall compliance and they require higher inflation pressures to maintain minute ventilation. They have decreased FRC, which will lead to VQ mismatch and hypoxia and reduced safe apnea time. They have increased risk of arterial hypoxemia. Pertaining to functional endoscopic surgery, which is a minimally invasive, low complication rate surgery, which could ideally be done as a daycare basis, but a patient like with obesity, daycare should be excluded. Considerations are, since the patient have nasal block, difficult mask ventilation suspected, and we have to use an oral airway to have an effective ventilation. Most of the patient with chronic sinusitis may have a coexisting asthma, COPD, bronchiectasis, and obstructive sleep apnea. And patients for rhinological surgery, they require hypotensive anesthesia and topical vasoconstrictors. But a patient with obesity associated with coronary artery disease, systemic hypertension, and CVA, we have to be cautious in giving hypotensive anesthesia. Pre-op instructions, lifestyle modification, alcohol and smoking cessation. We have to continue their own medications except oral hypoglycemic agents, angiotensin converting enzyme, renin blockers, antiplatelet, anticoagulations. Patients should have adequate NPO, anti-aspiration prophylaxis to continue and bring their own CPAP or BiPAP equipment perioperatively, to initiate CPAP and incentive spirometry preoperatively, to avoid sedative pre-medications, and we have to remind the patient that post-operatively their nose will be blocked or packed and they have to be cautious to breathe through their mouth. Appropriate equipments for transferring, accommodating and monitoring a obese patient. Intraoperatively, the plan is to administer general anesthesia with endotracheal intubation with rapid sequence induction. Also awake fiber optic through oral route depending upon the difficulty. The position would be RAM position or held position. In held position, difficult airway cord should be checked and kept ready. Skilled assistant to help with the burp maneuver or to help with the 2-person bag mask ventilation should be available. Cricothyrotomy kit to be ready, and landmarks for FONA should be done before induction. ENT surgeon should be present before induction. Extra large BP cuffs and ECG with larger size complexes should be available. Saturation probe and a peripheral IV venous access should be made before induction. Position for functional endoscopic sinus surgery will be supine position with a reverse Trendelenburg. Arms by the side of the patient. Pressure points should be adequately padded to prevent nerve injuries. And after adequate pre-oxygenation, induction with propofol according to total body weight 1 to 2 milligram per kg. After check ventilation, succinylcholine or rocuronium is administered. Fentanyl should be given as per lean body mass. Airway is secured with endotracheal tube, preferably the tube is fixed on the left side. Throat pack, if kept, it should be documented. Eyes should be carefully lubricated and covered. Ventilation is preferably a controlled ventilation with a pressure control mode with a PEEP maximum of 8 to 10 centimeter of water. Anesthesia is maintained with oxygen, air, sevoflurane or desflurane for rapid emergence. And nowadays, the first choice could be TIVA or TCI with propofol and remifentanil infusion to have a rapid emergence. Muscle relaxation could be maintained with atracurium. Fluids are given based on the lean body mass. Neuromuscular monitoring should be there to prevent incomplete neuromuscular blockade reversal. Adequate depth of anesthesia should be maintained throughout. To prevent blood loss, hypotensive anesthesia could be considered with caution in patients with CAD and CVA, and reverse Trendelenburg position with the 10 to 20 degree of head up to prevent congestion and bleeding. Analgesia can be maintained with a low dose of opioids along with paracetamol and NSAIDs if not contraindicated. Also with regional nerve blocks by blocking the anterior ethmoidal nerve, infraorbital nerve, and greater and the lesser palatine nerve. 10 minutes before the procedure, we have to soak the gauze pieces with the local anesthetics and the topical vasoconstrictors, and the nose can be packed before the procedure, also after the procedure for post-op analgesia. Corticosteroids, dexamethasone 0.15 mg per kg IV as an antiemetic to reduce the edema and bleeding. Reversal and extubation should be planned appropriately. We have to remove the throat pack and document before extubation. Inspect and suction the pharynx before reversal to look for any retained clot or secretion. We have to ventilate the patient with 100% oxygen before reversal and extubation. Ensure full reversal of neuromuscular blockade with neostigmine or sugammadex. Extubate once the patient is completely awake, obeys commands, and maintaining the airway and spontaneous ventilation. Post-operatively, the patient should be in highly dependent unit or intensive care unit. Patient should be nursed in head-up position to increase the FRC to decrease bleeding and aspiration risk. Supplemental O2 therapy or CPAP BiPAP should be continued for at least 3 days post-operatively for an obese patient. Pain is usually mild to moderate, so paracetamol or NSAID is sufficient. Also, the regional nerve blocks can be given. Antiemetics at appropriate dosings. Early mobilizations to prevent deep venous thrombosis. So that's all.
Okay, good. You have discussed it as though it is a theory question. But here it is a case scenario given, it gives the age of the patient, gives the comorbidity of OSA present in that, and the surgery. Isn't it? A 25-year-old patient with a BMI of 35 with OSA coming posted for FESS surgery. That is the scenario given. So if it is a practical exam and the scenario or a patient like that is kept in the exam, you don't have to go for general description of all the management of obesity and other things. Your discussion should focus more on the nature of the patient that has been given here. Okay.
Yes,
So in this patient, they have already said there is a OSA in that patient. So you must have more history pertaining to the OSA, how it was diagnosed, whether he himself experienced, because many patients who develop OSA, they are not aware that they are having this obstruction in the night. It is somebody else who will point out that they are having this sort of obstruction. They will just suffer all the consequences of OSA like early morning headache, lack of attention, somnolence during day. All these things they will take part of their lifestyle. I mean, regular life. Unless somebody finds out that this is all a sequence of OSA, majority of the patients think that they are just snorers and ignore that. So you must go into the details of finding out how this patient was diagnosed to have OSA, whether he is already married and is the spouse who was responsible for identifying that he is a heavy snorer and he is having all these sequences of OSA. And then they consulted a doctor and then they found out that they have, and whether they have been already advocated remedy like using a CPAP or a BiPAP machine, how long he has been using, and whether there are any evidences of pulmonary hypertension in these patients because of the chronic obstruction they suffer from, whether there is any right heart problem. All those things have to be given more importance and discussed with the, detailed history should be elicited from the patient. Okay. The other thing is you mentioned about maintaining airway by intubation. What type of tube you would like to use for this particular surgery?
Sir, here we use normal Portex tube, sir, but we can use a flexometallic tube or RAE tube with south facing.
That will be a oral ray tube or a flexometallic tube will be a better choice than using a regular cortex tube because of the fear of kinking that can happen. And so in the exam, even though in practice you are using your regular cortex in your hospital, please don't mention that in your exam, because the ideal method of intubating and maintaining the airway by using a cortex or a, the flexometallic or a oral cuffed air adult ray tube. Okay.
Okay, sir.
And throat pack is becoming controversial. Earlier, they were regularly, especially the surgeon used to ask the anesthetist to pack the throat, because we only know how to pack it around the glottic and on either side of the tracheal tube. But they have found that this packing is causing more problem like post-operative pharyngeal irritation and sore throat and all those things. And it is not, once you use a cuff tube, there is no fear of aspiration. So the packing the throat is becoming controversial, and majority of the recommendations don't advocate packing the throat with soap, saline soap gauze paste. And the incidence of forgotten throat pack or left out throat pack are more. And if at all you pack the throat, there should be a mention in the board that is kept in the OT about how many sponges, how many pads you are using. That should be similarly, that in that board you should mention throat pack, what time it was done, and removal of the throat pack at what time done. Both should be maintained in that or written in that board, so that you don't forget removal of the throat pack. And with regard to the surgery, as you said, it is a endoscopic surgery. What are the indications for this surgery that you never mentioned? What is the clinical or pathological condition for which functional endoscopic surgery is being done?
Chronic sinusitis.
Chronic sinusitis, which is not draining properly. Okay, they are getting infected repeatedly. So patient must have suffered a chronic sinusitis problem. So they might have had repeated treatment with antibiotics, different antibiotics at different time. And they may also develop some polyp because of the mucosal hypertrophy, which may protrude through the ostium of the sinus and block that. And so they may require a polypectomy, or sometimes a major procedure called Caldwell-Luck, which is not an endoscopic procedure, but it's an open procedure. So when they want to do all these things, packing the nose if there is a polyp already will be problematic. So in such cases, the surgeon might like to infiltrate with xylocaine and adrenaline before they start the procedure, so that bleeding will be very much less. So apart from the head-up position and hypotensive anesthesia, the commonest method that they use is using xylocaine adrenaline. And so the surgeon must be aware of the concentration of adrenaline that is present in the solution. So you must also discuss with the surgeon whether he is going to use the regular, what are the concentrations available in the commercially available xylocaine adrenaline preparations. Do you know what is the amount of the percentage of adrenaline that is present in our
1 in 2
commercial
lakh percentage.
1 in 2 lakhs for skin infiltration, but what dental?
No idea.
Dental, it is 1 in 80,000. Okay, it is much more stronger dose of adrenaline. So you must make sure that which adrenaline the surgeon wants to use. 1 in 2 lakh is quite safe, because how many micrograms is present in 1 ml if you use 1 in 200,000?
5
5
mics.
mics per
5 micrograms. And what is the 5 micrograms per ml is the dose, and what is the maximum you can use for a patient?
15 mics, sir.
It is 5 mics per kg. Okay, 5 mics per ml is a concentration that is present in 1 in 200,000. And the maximum safe dose is 5 mics per kg also. So if your patient is 100 kg, you can use maximum of 500 mics. Okay. So that is 5 mics per ml is the concentration. 5 mics per kg is the safe dose that can be used. So when a surgeon is trying to use that, you must have a discussion with him, find out what is the preparation and how many ml of safe dosage you can use. And lesser the concentration of adrenaline, the advantage is it will produce more local effect of vasoconstriction. It will not get absorbed into the system and it will not cause the systematic effect of tachycardia and hypertension. All will not happen. So that is another thing. And the examiner may ask you how you give hypotensive anesthesia, especially in FESS cases. The surgeon and the examiner wants to know how you can provide hypotensive anesthesia. What are the pharmacological agents that you will use? What is that? What is the answer for that?
So depend on the heart, we can use NTG, metoprolol, or short doses of esmolol.
Okay. What is the disadvantage of using these drugs?
NTG will
Advantage and disadvantage. NTG, if you use, what will happen to the heart?
tachycardia. It will lead to tachycardia.
Where is the action of NTG? Is it arterial dilator or a venodilator?
So at low dose venodilator, at higher dose both arterial and venodilator.
Venodilator. So if the vessels dilate, will it bleed more or will it bleed less? The surgical field. Huh? So the vasodilatation produced by most of the hypotensive agents will cause more bleeding. So many surgeons do not prefer to have that. So what is the current drug which is recommended for this particular providing a very good low bloodless field?
Tranexamic acid.
Tranexamic acid has to be given at the beginning of surgery, but during intraoperatively.
Clonidine, sir?
Second generation of clonidine. Next generation of clonidine.
Dexmed, sir.
Dexmedetomidine. Yeah, that is the panacea nowadays for everything. Dexmedetomidine. What is the advantage over NTG?
Analgesia.
It does not cause vasodilatation like the NTG. Okay, so there will be less bleeding in the field, and it also reduces the heart rate and reduces the BP. So the preferred drug for producing hypertensive bloodless field is usage of dexmedetomidine rather than going in for our conventional olden days NTG. Okay, that is the thing that you have to remember with these particular cases. And post-operatively, as you rightly said, patient has to be told that he will have to breathe through the mouth because the nostrils and nose will be packed with the gas. But is there any way to make him breathe through the nose also with the packing?
With the packing.
With the packing. They have some special gadgets now which can have a tube going through that, through the posterior nasopharynx, and that will be surrounded by a sponge. Okay, the sponge packing with a breathing tube, and also some of them will have a string attached to that so that you can pull it without the chance of this packing going down the nasopharynx and going into the oropharynx. Okay, so that is a modern thing. So patients need not worry about breathing, but it is always better to counsel and tell the patient that they will have their nose packed at the end of the surgery, and if the breathing tube is not present in the packing, patient has to breathe only through the oral cavity, and unless you counsel them and tell them, some patients will become very restless because the nose is blocked and they are not, they take some time to adapt to breathe through the mouth. So in that case, better to insert a oropharyngeal airway before you extubate these patients so that they can have a free passage to breathe. Okay?
Yes, sir.
And post-operative bleeding through the nostril. Surgeon should do a good suctioning, otherwise a clot that is formed in the posterior nasopharynx can slip down and come and obstruct. What is the name of that clot that can go to the nasopharynx?
Coronus clots.
Coronus clot. Just like your after adenoidectomy, you get that. This can happen in this particular surgery also. Okay. So I'll just share the screen for you. This particular procedure. So this is the case scenario that you have. The problems in this case are, and you have to give the class of obesity. That I forgot. The BMI 35 belongs to class 2 obesity. So in the exam, if they give you the BMI value, then you say which class of obesity the patient is there, and he has already been diagnosed with OSA. So all the details about OSA is very important. And it is FESS surgery, the intraoperative requirement of force of the airway and problems. So preoperatively, because he is also obese already, you have to have a very good assessment of the airway and severity of OSA, whether patient is under any treatment already for the OSA. And pre-op optimization, counseling regarding packing of the nose in the post-op period, and ask him to do adequate breathing exercise and increase spirometry to prevent any airway complications. Intraoperative, sometimes FESS is done under LA also, the local anesthetic packing as well as infiltration. This can be done under LA also. But anxious parents, patients or patients who have a problematic airway, it is better to plan for a GA and do for that. And they have done FESS surgery under LMA with a flexometallic LMA tube also. But in cases of obesity, it will be safer to go for endotracheal intubation rather than depending on the LMA alone. And the third options are inhalation versus TIVA. So these are the three different dilemmas that you will have, whether to give GA or do it under LA, whether it is EP tube or LMA, whether it is inhalation or whether TIVA. And obese patients, it is better to go for TIVA rather than inhalation, and because the recovery can be predictable and easy to titrate. And remifentanil combined with propofol or usage of inhalation agents with oxygen and air also are practiced regularly. And selective alpha-2 adrenergic agonists like clonidine or dexmedetomidine, which cause hypotension without vasodilatation. That is the advantage of this drug. They reduce bleeding and improve surgical visualization in FESS surgery. And also, their other advantages are they have some analgesic quality also. So you can avoid using opioids. And at the beginning, you can give tranexamic acid, either IV, 15 milligram per kg body weight. And then the reverse Trendelenburg position, which is normally adopted, also allows the venous drainage to happen and reduces the bleeding. And preoperative steroid administration will have not only anti-inflammatory effect on the mucosa, which improves the visibility, as well as it also has the anti-emetic effect. Dexamethasone has an anti-emetic effect. And vasoconstrictors like cocaine and epinephrine and phenylephrine can be used to reduce the bleeding, either topically. Epinephrine can be, and phenylephrine can be injected also. Maintenance of normothermia is important for the normal functioning of platelets and coagulation factors. And controlled hypotension refers to a deliberate lowering of systolic BP to less than 20% less than the patient's baseline blood pressure. So that is the definition of the other names for controlled hypertension are, what are the other names for controlled hypertension? Deliberate hypertension, hypotensive anesthesia, all these things are the other names for that. Now, Sometimes the examiner may suddenly ask you about cocaine. What is this cocaine?
It's a local anesthetic with sympathomimetic properties, sir. Mimetic.
Mimetic. What do you mean by that?
It causes vasoconstriction.
Vasoconstrictor effect. You can say like that. It's a local anesthetic, vasoconstrictor. Who discovered the properties of the cocaine and used it first in anesthesia?
Sir, it was used for ophthalmic surgeries, sir.
By whom? He is considered as father of local anesthetic. That is the first time local anesthesia was invented. It is by Karl Kroller. Karl, Karl, Kroller. Karl Kroller was a German ophthalmist. He is a Vienna, from Vienna ophthalmologist. He was working with Sigmund Freud. Who is Sigmund Freud? Have you heard of that?
Psychologist.
Psychiatrist.
He is a psychology or a psychiatrist who was a pioneer in the field of psychiatry. So they used to get cocaine leaves in the tribal people used to chew the coca leaf and climb the hill without any difficulty for a very long distance. They just pluck these cocaine leaves and then chew it and then take it. That gives them the euphoria as well as strength to climb the hills without any tiredness or fatigue. And he was doing a research on that particular leaf. And Karl Kroller was working as an assistant with him at the time, Sigmund Freud. And Freud has gone to a conference to present some paper. At the time, Karl Kroller, what he did was he put cocaine leaves in his mouth and was chewing. And he was examining an eye of a patient. Suddenly, a drop of his saliva with the cocaine after chewing the leaves fell on the patient's eye. And the patient who was resisting the opening and examination of the eye suddenly became very cooperative and opened the eyes very comfortably. So he found that something is there in the saliva and then identified that it is the cocaine which is present in that, and he published a paper of the efficacy of cocaine as a local anesthetic. And Sigmund Freud came to know of that and dismissed him from his assistant job and sent him out. So those days, those things were all very common. Somebody stealing somebody else's work and publishing in their name are all quite common. So it was Karl Kroller who did that. So with regard to this cocaine, there is one particular question. What is a Moffett solution? Moffets. Have you all heard of that name?
No, sir.
No. Moffett solution is actually Colonel Moffett was a ENT surgeon who used a combination of cocaine, adrenaline, and sodium bicarbonate for all nasal surgeries done under LA. So using the local anesthetic property of cocaine, he used 5 to 10% of cocaine 2 ml as a liquid. He used 1 ml of adrenaline, and he used sodium bicarbonate and saline to make up a total volume of 10 ml and injected it to produce a nice bloodless field, and at the same time a pain-free patient was undergoing operation. So this is the combination. Cocaine is commonly used in Moffett solution. So sometimes if you answer very well, they want to give you a distinction mark, they may ask you this. And this is sometimes asked in the theory paper also. A mixture of 1 to 2 ml of cocaine 5%, 1 ml of adrenaline 1 in 10,000, 2 ml of sodium bicarbonate 8.4%, made up to 10 ml with 0.9% sodium chloride. This is called the Moffett solution, which was used in the olden days. And I thought of just telling you about asking you about the nerve supply of the nasal cavity, which is very important, asked in the examination when you want to do a awake fiber optic intubation or a blind nasal intubation. The examiners want to find out whether you have any idea about the nerve supply to the nasal cavity. Vidhya, can you tell me what are all the nerves that supply the nasal cavity?
So the ophthalmic and the maxillary branches of trigeminal nerve.
Very
which
good.
gives,
What are the further branches of that? These are major branches: ophthalmic, maxillary, mandible. These are the three branches. That's why it's called trigeminal nerve. Of that, the V1 and V2, trigeminal 1 and branch, which is ophthalmic, and trigeminal 2 branch, which is maxillary. They are the main suppliers. But they further divide into what type of, what are the names for the further branches of these major branches?
so infraorbital nerve, anterior ethmoidal nerve, greater palatine and lesser palatine nerves.
This all from the ophthalmic?
Mesociliary nerve. Both from ophthalmic and maxillary.
You must say individually. Ophthalmic branch
ophthalmic
gives the ethmoidal as
mesociliary.
well as the infraorbital. Whereas the
Infraorbital nerve,
maxillary gives the nasociliary, which
and
goes
lesser
down
palatine.
into superior alveolar, greater palatine, lesser palatine. Okay? So that is it. So this picture gives you all the names of the branches. So you can see this is the pterygopalatine ganglion. So palatine nerve, lateral posterior superior nasal nerve. This is the lateral posterior inferior nasal nerve. Lesser palatine, greater palatine. All these are branches of maxillary branch. The ophthalmic branch comes as an external nasal branch, anterior ethmoidal, and also infraorbital. Okay, so these are the nerve supply. For the olfactory, the smelling, it is by the first cranial nerve, olfactory nerve. All of you know that. For the sensation to the nose, septum, etc., these are the branches from ophthalmic and maxillary. And the ophthalmic nerve branches into nasal septum, gives of anterior ethmoidal, and which supplies the upper part of the septum, nasal tip, and lateral walls. It also innervates the ethmoidal, sphenoid, and frontal sinuses. Maxillary nerve traverses the pterygopalatine fossa, where it forms the pterygopalatine ganglion. Branches include greater and lesser palatine nerves. Terminal branches of maxillary are the, this infraorbital is for the maxillary, which supplies the maxillary sinus and skin immediately lateral to beneath the nose. And postganglionic parasympathetic fibers, they are from the facial nerve, travel with the maxillary nerve branches to facilitate secretomotor functions of the nasal and sinus mucosa. Okay? So these are all the various nerves that are supplying this. Okay, so that will push the discussion on the three cases. We move on to Osce.
Yes, sir.
Okay.
Yes, sir.
The other case that we did. So what is the condition shown in this picture?
Gastroschisis.
Gastroschisis. So what is the other thing that abdominal wall defect can produce in a newborn? Omphalocele. How do you differentiate between omphalocele and gastroschisis?
Covered by sir.
Which is covered and which is through the umbilicus. Gastroschisis, which is lateral to the umbilical cord and which is not covered by the sacs.
Very good. So it's a case of gastroschisis, usually seen as a conjunctive problem in neonate. Why this condition needs urgent surgery?
So it will
Viscous
rupture.
infection.
Since it is not covered by the sac, it will lead to rupture and dehydration.
Ischemia and infarction. Okay, surgery, bowel is exposed, fluid and heat loss may be significant. It can also have compromised gut circulation leading to ischemia with infarction of the gut, which may require resection and anesthesia in the major procedures. What are the complications of a single stage surgery in these cases?
Compartment syndrome and bowel ischemia.
Intra-abdominal pressure will increase. Abdominal
Pulmonary,
compartment syndrome.
pulmonary poor compliance.
Upward shift of the diaphragm interfering with ventilation. And this can decrease abdominal organ blood flow also. Okay. And reduction in renal perfusion can result in oliguria and anuria, or vascular injury to the intestine may result in gut necrosis, and reduction in liver perfusion will result in hepatic impairment. So all these post-surgical complications are quite common in these cases. And forceful closure of the abdominal wall will also cause a significant tension in the skin and the increased incidence of dehiscence, wound dehiscence, and secondary infection is very common. What history is important in pre-op assessment of these cases?
Electrolytes, sir.
Electrolytes.
Pre-op assessment. If it is term or
Gestational age, but history whether baby has had vitamin K or not. Okay? So that is a very important because they may have vitamin K deficiency and the absorption of the skin will not be there. What NICU management may be needed in these patients? Neonatal intensive care.
So they require bowel decompression and hydration, fluid and electrolyte management.
Mechanical ventilation due to temporary deterioration in lung function due to raised intra-abdominal pressure, and so may require total muscle relaxation for 24 hours till the bowel content is accommodated in the abdomen and the abdomen gets accommodated to that pressure. Okay, so we may need a total paralysis and mechanical ventilation to maintain that. Body temperature needs to be maintained. Hypothermia is very, very common. Okay? And analgesia produced with IV morphine or an epidural infusion of local anesthetic or paracetamol should be also considered. So these are the three requirements in the NICU: mechanical ventilation with total muscle paralysis, especially if the bowel exposed is too large, there is a tension in the abdominal wall, temperature maintenance, and proper pain control. What is shown here and what is the difference between the two
pressure volume loops of
pressure
the
volume
left ventricle.
loop?
One is a normal loop.
The other one is
Systolic failure.
Mitral stenosis.
mitral stenosis. Yes, it is shifted to it's a pressure volume loop in case of mitral stenosis compared with the normal pressure volume loop. The shaded figure is shifted to the left and has a lesser volume and pressure. Okay? That's what happens in the left ventricle in mitral stenosis because of the inadequate filling. Okay? How many phases of are there in pressure volume loop and what do they indicate?
4 phases. Sir.
4 phases. Very good. What are the 4 phases?
It is from A, B. It is marked as A, B, C, and D, sir.
One starts with mitral valve.
After all 4 phases of cardiac cycle, no? That's all filling. So PV loop has 4 phases, correct? Phase A is ventricular filling, which is diastole. Phase B is isovolumetric contraction. Phase C is ejection, and phase D is isovolumetric relaxation, which happens in the diastole again. So 2 phases in systole and 2 phases in diastole: filling and relaxation, contraction and ejection. So these are all the things that you have to. So as I said, A, B, C, D, it's a mark like that. So these are the 4 things that are. What is the use of PV loops and what is their limitation?
We can measure the ejection fraction, sir.
Ejection
In
fraction.
real time, it can be measured, sir.
Is it real time? What is the doing? Is it real time or you are just plotting?
We are just plotting, so not real.
It is not live. It is not real time. Okay. PV loops are valuable tool for research and decisions. Their limitations are they only represent a snapshot of cardiac cycle. Interpretation of PV loop relies on assumption about heart function. Real-time pressure can only be obtained through invasive catheterization. Okay? So these are only plotted based on the non-invasive method. What is the most common arrhythmia in mitral stenosis? What are the goals in its management?
Atrial fibrillation. sir.
Atrial fibrillation. What are the goals in the management?
According to the time period, it is rate control, rhythm control, and anticoagulation.
Very good, excellent. So this is the arrhythmia is atrial fibrillation. These are rate control, rhythm control, anticoagulation. Can a single shot subarachnoid be given in a pregnant patient for cesarean section?
Yes, sir.
Depends on the severity of
Not
mitral.
for severe MS, sir. For mild to moderate MS, we can give.
We can give. What are the precautions you have to take? If you have to
We have
give?
to load the patient.
Load the patient.
Preoperative hydration should be judiciously done, sir,
Hmm.
so that hypotension should be avoided.
Okay. But too much of loading will also cause there is a fixed output
Yes, sir.
syndrome. So you may cause ventricular overload. Isn't it?
Yes, sir.
Yes, sir.
Forward flow is obstructed. So you have to do only what is called co-loading, not preloading. Okay, that is number one. Number two, you must restrict the height of the block because it cannot compensate by tachycardia. So tachycardia will worsen the condition. So the height of the block should be judiciously stopped with up to T10, even though you require T4 blockade for cesarean section. Why you require the actual nerve supply to the uterus is only from T10 to L2 for the body and fundus of the uterus, and the lower passage is from sacral S2, S3, S4. But why do you require a block up to T4 for cesarean section?
Stretching
The
of
stretching will be there.
This becomes an
Huh?
intra-abdominal
Frequent
organ.
stretching.
Extra abdominal organ. Which is extra abdominal organ? Whether it is intra-abdominal or extra-abdominal, nerve comes from the same segment of the spinal cord.
the surgeon includes stretching of the
Stretching
peritoneum.
the peritoneum, sir.
Surgeon does not increase. Two things, one is fundal pressure applied during delivery causes a stretch on the peritoneum. Okay, surgeon wants to deliver the baby through the incision in the lower segment of the uterus, for which they apply what is called fundal pressure. At the time, the peritoneum, which is covering the top surface of the uterus and the anterior surface, will be stretched. That will cause some discomfort. It is not actually a pain, but to block that, you require up to T4. And sometimes they do what is called exteriorization of the uterus. They, after making the abdominal wall incision, like a pan and steel incision, some gynecologists have a bad habit of putting their hand underneath the uterine cavity, the uterus, and then taking the whole uterus out of the abdominal wall and keep it in front of their eyes and try to deliver the baby. But a good gynecologist will never do that exteriorization, which is very uncomfortable to the patient. So by restricting your block up to T10, which is the actual nerve supply to the uterus, body and fundus, how will you avoid the discomfort of this fundal pressure or exteriorization?
Can give IV sedation.
Maybe sedation with what? You must not generalize. You must say which drug you will give, what dose you will give, which is low dose
Ketamine.
can be
Yes,
given.
sir.
Yes, 10, irrespective of the body weight, 10 to 15 milligram of ketamine produces excellent analgesia of a very short duration. Okay, without
Yes,
the usual side effects of tachycardia and hypertension, which happens with a regular IV dose of 1 to 2 milligram. Just 0.1 to 0.2 microgram per milligram or 100 to 200 microgram per kg produces a very short duration, very powerful, intense analgesia. So that can be done for managing this fundal pressure. Once the baby is delivered, automatically this discomfort will disappear. So by restricting the volume of the local anesthetic given subarachnoid to maximum 1.5 to 1.75 ml, you can add 25 micrograms of fentanyl, which will also control this discomfort. Or you can give IV ketamine 10 to 15 milligram dose, blanket dose, which is not based on body weight or anything, that also will take care of this problem. Okay. What is shown in these two x-rays?
Cobb's angle
Cobb's angle, sir.
measured in
Cobb's
a
angle
scoliosis
class.
scoliotic.
Okay. So measure the Cobb and angle lines are drawn at the end plates of upper and lower vertebra of maximum curvature. The angle between the two lines where they intersect are measured. Okay. But there is another case where they don't meet. So in that cases, what you do is given in the second picture. So this is a classical method of calculating the Cobb angle. You draw lines from the top and bottom vertebra. They intersect each other. In case they don't intersect each other like this, where they go straight like that, then you drop a perpendicular line from both, and that also the method of calculating. So they can ask you without this actual way of calculation, just the blue lines X-ray they can show you and ask you how will you calculate if they are not intersecting with each other. What are the causes of pulmonary hypertension? What pulmonary hypertension, why does it happen in scoliosis?
It's because of restrictive lung disease.
It depends on how much of lung tissue is affected. Whether the lung growth has been affected from the intrauterine life itself, or whether normal growth has happened only later on. Scoliosis has happened. So decreased lung compliance, compressed lungs, increased pulmonary vascular resistance, respiratory muscle weakness, alveolar hypoventilation are all the causes of pulmonary hypertension in scoliosis. Why modifications in intraoperative anesthesia needed if neuromonitoring is planned during scoliosis surgery?
We have to avoid the
Because it
patients
intervenes
between
with the,
the
it will affect
to
the
affect the
amplitude and the
sensor.
latency of the monitoring.
Excellent. So neuromuscular blockade will avoid the motor response to evoked potentials, number one. If you use inhalation anesthetic agents, they will prolong the latency and also the amplitude of the response curves. So neuromuscular blockade will avoid eliciting of evoked motor potentials. Use of volatile agents, we have a avoided to have a normal latency and amplitude of the stimulus. So how to manage blood loss in multi-level scoliosis correctly?
you can go for
Position.
autologous transplant.
Adequate
From the
positioning,
beginning.
adequate positioning, pre-optimization, adequate positioning, hypotensive anesthesia, use of tranexamic acid infusion.
So injection tranexamic acid can be administered before the start of the surgery. Correct positioning is important. Hypotensive anesthesia, hemodilution by preoperative autologous donation or acute normovolemic dilution, local hemostasis by injection of adrenaline saline or tumescent, cell salvage. Okay. These are all the methods of managing blood loss. So 1, 2, 3, 4, 5, 6. Identify the items shown here. What are the dimensions of the needle and catheter?
Epidural catheter kit, sir, which has a loss of resistance syringe. Epidural needle, 2E needle.
Needle 18 gauge,
Epidural
8
catheter.
centimeter length, and catheter, which is with radio opaque markings.
What is the gauge of the catheter?
So it will be 2 gauges higher than the 2E needles. Usually it is 2 gauges higher than the 2E needles.
Higher, then how will it go inside the needle?
Sir, higher the number, lower the dimension.
So you have a pediatric, this is a pediatric epidural set. We have a 18 gauge tubing needle, total length of 78 millimeters. Penetrating part is 15 millimeter long, and it is a 19 gauge catheter. Overlock catheter connector for the catheter, that is E, and 10 ml loss of resistance. Okay, right. So the gauge number, the size becomes smaller when the number increases. Whereas in French gauge, higher the number, higher the size. Okay, that is the difference we have to remember. What is the full expansion for gauge? Is G. Is it simply you have to call it as a gauge, 18 gauge, or is there a full name for that? Is SWG. What is the expansion? It's not simple G, it is SWG, but for easy writing, we just may write it as 18 gauge, 17 gauge and all. But actually it is SWG. What is that SW stand for? Standard wire gauge. Okay, this SWG or standard wire gauge is the full expansion. What are the methods of identifying epidural space? What is the principle behind these methods?
Principle is it's a potential space, sir, so that it will have negative pressure. So we can use loss of resistance, hanging drop method.
Loss of resistance to what?
To
Air,
and
air or
saline.
Air
saline.
or saline. Okay, both you have to say, air or saline. Even though commonly you use air, you have to mention about air or saline and hanging drop. And potential, what is the cause of negative pressure? Is it just because it is a potential space, it is negative, or something else? Is it connected to any other space, epidural space, especially in the thoracic region?
Parabol.
It's connected to the pleural space, which has a negative pressure. Okay, so that is the main reason. Methods of identifying are loss of resistance to air, loss of resistance to saline, and hanging drop. The principle behind there is a negative pressure in the epidural space, which gives the loss of resistance field, which is mainly because of the connection with the interpleural space also. What are Stout principles for spread of solutions?
So it defines the height of the blockade, which is directly
Speed of-
proportional to the volume of the drug, directly proportional to the concentration of the drug, and directly proportional to the speed of injection, and indirectly proportional to the height of the patient and the position of the patient.
Okay.
Specific,
Indirectly
proportional to the pressure, sir, a series of pressure and rate of
Proportional to
fixation.
final fluid.
so it is directly proportional to
fluid
the
pressure.
volume, speed and concentration, baricity of the solution, and inversely proportional to the rapid fixation and spinal fluid pressure. Okay, it is not due to the position or height of the patient. Height of the patient is directly proportional. Taller the patient, it requires larger volume, but it is inversely proportional more to the rapidity of fixation of the spinal and the spinal fluid pressure. What can happen if excess length of catheter is threaded into epidural space?
Will coil or displaced.
Oil, or it will go out through the foramen. Okay, this can have kinking, twisting, entanglement, shearing, or poor block quality because the catheter can move out of the epidural space through the intervertebral foramen also. Okay. What is shown here?
This infraclavicular block.
Fantastic, fantastic, very good. Use ISV guided in plane approach to infraclavicular block. All these things have to be mentioned. US guided in plane approach to infraclavicular brachial plexus. Which level of brachial plexus is blocked by this approach?
Medial cord,
The
posterior
root
cord,
or the
and
trunk?
lateral cord.
Trunks and
Cord.
discs.
Block at the cord level. What structures are passed through during this block?
Skin, subcutaneous tissue, pectoralis major, muscle, and
Pec minor.
pectoralis minor.
In the subcutaneous. What are the indications for this block?
And
Sir, upper limb surgeries below the shoulder level for forearm and
Below-
hand surgeries.
Can shoulder surgeries be performed using this block?
No, sir.
No, sir.
Oh, why?
It spares the
Supraclavicular. What are the other areas and nerves are spared in this block? These are three questions. What are the indications? Can shoulder surgery be performed? What are the other areas or nerves that are spared in this block?
suprascapular nerve, axillary nerve, and superficial cervical plexus will be spared.
What about intercostobrachial?
Intercostal bracket is also spared, sir.
Yeah. The infraclavicular block is used for surgery or post-op pain control of upper extremity, and it is suitable for hand, wrist, and elbow or distal arm surgery. The shoulder is not covered since superficial cervical plexus C1 to C4 innervated. The skin of the axilla, brachial medial arm requires additional intercostobrachial nerve block to provide full anesthesia. There may be incomplete radial nerve block sometimes. The radial nerve will be spoiled because it is more posterior to the axillary artery at that level. Name 3 common techniques of performing this block.
Costoclavicle, ultrasound guided and
Nerve stimulator.
Thoracoid approach, lateral sagittal approach, and the vertical approach. So these are the 3 approaches that are. Which Indian origin anesthetist is credited with the introduction of this block? Indian origin anesthetist who migrated to US and then Canada. He was a very popular figure and he has published a book, Regional Anesthesia, with various blocks. It is a very wonderful book. If you happen to get a chance to see that book, you will never forget the blocks in your life. Right. Pulchand Prithviraj. I don't know how many of you have heard that name. He actually visited Chennai about before his death in 2016. He died. 1 year before that, he came in a wheelchair and a meeting was held in Hyatt Regency in Mount Road. And I happened to have this article in one of the journals of regional anesthesia on management of chronic pain, in which the first sentence is chronic pain management is an enigma. And when he spoke in 2015, I quoted this and told him, "Sir, is it still an enigma or have you found out a solution for that?" And he said, "You are very correct, it is still an enigma. We are still yet to conquer chronic pain." That was what he said about that. Indian American physician. He was a very good interventional pain management specialist also. Spinal subarachnoid block is administered a term lady for emergency season in lateral position. On turning the patient supine, she developed bradycardia and hypotension. How do you manage that?
sir, lateralization of the uterus by keeping the wedge.
No, she has been given spinal in the lateral position and she is turned supine for surgery. Immediately she develops bradycardia and hypotension. How are you going to manage?
We have to administer fluid followed by
End up.
use of vasoconstrictor, like phenyl.
Phenylephrine will cause further brady.
Why are you not thinking of atropine? Bradycardia, hypotension, always because of a high block on atropine has to be the first drug. Actually, administration of high flow oxygen and encourage patient to breathe deeply, raise head up by 20%, administer atropine 0.5 milligram IV. Don't give epinephrine, ephedrine or phenylephrine first. First, always I did give atropine to raise the heart rate. That itself will correct the hypotension. In spite of the heart rate coming up after atropine, if still hypotension is persistent, then give ephedrine. Okay, ephedrine and phenylephrine is not the first drug of choice. So then increase infusion fluid, administer ephedrine if still BP is low. Okay, so first drug of choice in the exam if they ask you is 0.5 milligram of atropine IV. Brady with hypo. How to prevent this complication?
Adequate
The precaution.
adequate
Giving spinal in lateral position, the head should be little bit above the
Okay.
level.
This is the only way. All the methods you must say. So 20-degree head up tilt to the table is done in lateral position and a pillow under the shoulder, which is called the Oxford position. Adequate preloading with IV fluids and injecting correct small volume of local anesthetic drug that is required depending upon the patient's height. Injecting the drug slowly. All the Stouts principle you have to use. Can 5% dextrose be used for oxytocin infusion? What are the other problems if 5% dextrose is given? No idea? Okay. Use of oxytocin dextrose can potentially lead to water retention. There's risk of fetal hyperglycemia if 5% dextrose is given, and acidosis and neonatal hypoglycemia because of reflex insulin secretion. Why sitting posture is preferred for SAB in pregnancy? Subarachnoid block in pregnancy. What is the advantage? What are the advantages of sitting posture?
it open up the space. The patient have exaggerated lumbar lordosis. With the sitting position, the spine will be prominent and the space will be more when compared to lateral position.
Which is comfortable for a pregnant lady to crouch in the lateral position or sitting position?
Sitting.
Sitting position preferred when difficult to identify the landmarks as in obese patients or when combined spinal and epidural technique are attempted, and it is also easier for the patient rather than lying in the lateral position. What is the level of block required for CS and what will happen if level becomes higher? How to manage that?
Level is T4, sir.
T4. Okay. What will happen if the level becomes higher?
You can expect
Spinal
hypotension and bradycardia.
Bradycardia.
That is a cardiovascular effect. But what will happen to what will the patient tell you if the height is more than T4?
Not
Difficulty in
able to
breathing,
breathe,
Breathing
sir.
difficulty.
Not able to breathe. Yes. Why
And
they say
vomiting.
they are not able to breathe?
diaphragm and intercostal muscle
Diaphragm will get paralyzed.
Intercostal muscles.
paralysis.
They don't feel the act of breathing. Okay? That is the reason they become how to manage that.
Keep oxygen and head up
abdominal
position
oxygen.
and
Reassure the patient. Okay? Sensory block up to T4 to C6 is required. Beyond T4, level can cause sense of dyspnea as a feel of chest expansion and voluntarily shy or lost due to intercostal muscle paralysis. Reassure and encourage the patient to breathe deeply. That is all what is required. Once the baby is delivered, all these things will disappear. Okay, that is the initial thing. Some patients may become very agitated and restless because of that. So you have to tell them that nothing to worry about that. Reassure them. Even before giving spinal, if you tell them, they will be happy. What is peak pressure in mechanical ventilation? What is its aim and how is it calculated?
Peak pressure, which is the pressure combination of airway pressure and the compliance.
Pressure at which the lower esophageal sphincter could open up.
Lower esophageal.
Peak pressure is the
Maximum pressure during inspiration, sir.
Right. Peak pressure is the pressure generated by the ventilator to overcome both airway resistance and alveolar resistance. Okay. So peak pressure is a mechanically, that is, this word is important, mechanical ventilation. The pressure is generated by the ventilator to overcome both airway resistance and alveolar resistance. The aim of this pressure is to obtain the set inspiratory flow and the tidal volume that is set by provider to deliver that particular thing. And it is calculated by resistance and flow plus elastance of respiratory system into tidal volume plus the plateau. What is that? Deep. Okay. So what is plateau pressure and how that is calculated?
Plateau pressure is the alveolar resistance.
Complaints, volume and complaints.
Compliance with alveolar resistance.
The plateau pressure, what you see in the graphics, isn't it? Ventilator graphics, curve layer, only you see this peak pressure, plateau pressure, and all that. So this is a pressure that is essentially left over in the lung after tidal volume has been delivered. Okay, so the machine delivers the set tidal volume. After that, all the alveoli are fully ventilated. So the pressure that machine measures at that time is called the plateau pressure, and that is calculated by tidal volume divided by compliance. Okay, so that is how the pressure. So how to measure peak and plateau pressure at zero flow?
At zero flow, both are equal.
Equal. Inspiratory hold button has to be used. That is, it's a all question with regard to how to manage your ventilator. So if you want to measure peak and plateau pressure at zero flow, you have to press the inspiratory hold button for 5 seconds so that there is no flow at all. Then measure that. So what inferences are made by changes in peak and plateau pressure, and what are all the causes for that?
So if only plateau pressure raises, then it is the lung compliance. It could be because of obesity. If both peak and the plateau pressure raises, then it could be because of the airway resistance or compliance.
Excellent. Higher the peak with normal plateau, it is elevated resistance. Because as I said in the first thing, it is the pressure generated by the ventilator to overcome both airway and alveolar resistance. So if you require more peak pressure but the normal plateau pressure, that means it is the airway resistance is increased, alveolar resistance is normal. Whereas, so this is how the picture will be. This is the peak pressure, then this is the plateau pressure. So high peak pressure, normal plateau pressure, resistance issue. And resistance may be in the ET tube or distal bronchus, whereas high peak and high plateau pressures issue with compliance. So this is the picture that you will have. So you can see peak pressure is there, plateau pressure also is elevated. So both the things elevated, it is a compliance issue. Only peak pressure is elevated, plateau pressure normal, it is a resistance issue. So causes of both high plateau and peak pressures are pneumonia, pulmonary edema, autopsy, right mainstem bronchus intubation, pneumothorax, atelectasis, pulmonary fibrosis, and even abdominal issues like abdominal compartment syndrome. Okay. What is TIVA? What are the indications for its use?
It's total intravenous anesthesia, which uses the intravenous anesthetic drugs and avoidance of inhalational drugs.
Fantastic. This maintenance of general anesthesia without inhaled volatile anesthetic agents. Indications are malignant hyperthermia, risk of long QT syndrome, tubeless anesthesia, surgery requiring neurophysiological monitoring, myasthenia gravis or neuromuscular disorder, anesthesia in non-operative room, daycare surgery, history of nausea and vomiting, or trainee teaching. Patient may sometimes opt for that during transfer of anesthetized patient. All these things are the indications for TIVA. Which character of drugs make them suitable for TIVA? Why propofol and remifentanil are preferred?
The context sensitive half time is
Very good. Should be all. Drugs with a faster onset and offset of time are more suitable for TIVA. And propofol and remifentanil have short or minimal contact sensitive half-time, meaning decline in plasma concentration agents slow as the duration of infusion increases. What is the principle in target control infusion, TCA, compared to TIVA?
Is the pharmacokinetic
It maintains a steady state concentration by delivering
What two terminologies you should use?
Reset determination.
Concentration.
effective
Ah.
concentration and
Plasma
concentration.
plasma concentration, effector site concentration. Okay. So first, initially, a bolus elimination transfer principle is used to approximate a constant plasma level of the drug. So that is the basic principle. But what is CP and CE and their relationship?
which is CP is the plasma concentration of the drug, CE is the effect site concentration of the drugs.
We
What
can
is
set
the-
either of these in the TCA pump, sir. But setting the effect site concentration will be more efficient than setting the plasma concentration.
Plasma concentration. So CP is plasma concentration, CE is effector site. The peak clinical effect of a given plasma concentration of a drug is achieved a few minutes later due to delay in equilibration between plasma concentration and the effect site. Okay. So what factors are involved in the delay of achieving equilibrium?
Redistribution, sir.
Very good. Lipid solubility, degree of ionization, cardiac output, cerebral blood flow. Mention few disadvantages of TIVA.
Depth of anesthesia cannot be monitored unless we use bispectral index.
Very good. Okay.
Muscle relaxation may not be given with only may not be adequate with only TIVA.
Okay.
We can give a
Any problem with administration, the set and the instrument? So awareness is one problem. Variations in hemodynamic state, need for reliable intravenous access, requires specialist training, risk of disconnection, variability in response to injected agents. All these things are the disadvantages. A 50-year-old man with no significant medical history undergoes a decompressive craniotomy for an acute subdural hematoma following a traumatic head injury 24 hours ago. Okay. He is now in neurosurgical intensive care unit and remains intubated and ventilated. Despite appropriate intravenous fluid administration, his urine output has been 800 ml over the last 2 hours. Given the likely diagnosis, so the following additional findings is more consistent with the patient's condition. 1. Urine specific gravity more than 0.005. Serum sodium less than 135. Urine osmolality less than 300 milliosmoles. Serum osmolality less than 295.
urine osmolality less than 300 milliosmoles per liter.
Okay, correct. Excellent. What is the cause of this polyuria in this case? Which other
Diabetes
condition?
insipidus.
Syndrome of inappropriate
Diabetes.
Okay.
Sorry.
Arginine vasopressin deficiency or SAID associated with traumatic brain injury causes polyuria. Subarachnoid hemorrhage and pituitary surgery are other causes for this condition. What lab findings confirm this condition? What is the normal urine osmolality?
is 600 to 800 milliosmoles per liter. Normal urine.
So
We have
abnormally
also-
low urine osmolality associated with hypernatremia indicates presence of arginine vasopressin disorder or deficiency. Normal osmolality is 500 to 850 milliosmoles per kilogram of water. What are the other causes of increased urine output in the absence of this arginine vasopressin, and how are they identified?
Hydrogenic administration of IV fluid.
Very
We can
good.
restrict IV fluid administrations.
Excellent. So excess fluid administration or an osmotic diuresis like mannitol or glucocorticoids and also cause polyuria. Differentiated from ATP when measuring the urine osmolality in response to water restriction and antidiuretic hormone administration. That is how you can differentiate. What do these arrows point out? Pointed.
J point.
Huh?
J point.
J point.
VPC.
VPC, sir. Ventricular
Ah.
premature contractions.
Premature ventricular. Any other thing to be said? This is both are the same or different?
No, sir, different.
What is the difference?
Morphologies.
Axis is different. Sinus rhythm with PVCs of two different morphology. So this is a negative, this is positive. Okay, so it can be a positive VPC or it can be a negative VPC. So it is a multifocal ventricular premature contractions. It's a sinus rhythm. What is seen in this ECG? Compared to the above, what do you see?
Monomorphic.
Multiple monomer, non-sustained VT. So when you have a single morphology and it occurs continuously, it's called non-sustained ventricular tachycardia. How do you classify the PVCs?
Atrial and VPC.
PVC, ventricular. PVC stands for premature ventricular contractions.
Sustained VT and
Multifocal, rising from a single ectopic beat, or multifocal. Okay, just like this. This is multifocal, this is unifocal. Single reflection on the positive side. How to find out the origin of VPC, whether it is single ectopic or more than ectopic.
with the help of morphology.
PVC arise from right ventricle, have a left bundle branch block morphology. S wave in V1. And PVCs arising from left ventricle have a right bundle branch block morphology with the R wave in dominance. So this will be the picture. If you see the lead V1, if you have a R wave domination like an RBBV, it is the arising from left ventricle. Okay? If it is the LBB type, the deep S wave, it is arising from the right ventricle. So VPC can arise from the right or left ventricle, ventricular premature. So you can find out by this particular method. When does a PVC become significant?
If it is
More
than
than 7
Brain of frequency of PVC are usually benign except in context of prolonged QT interval. Then they be more predisposed to malignant ventricular arrhythmias such as Osce points causing R12 phenomenon. So you must measure the QTC in all cases of PPD. What is the role of perioperative IV lidocaine in anti-neoplastic and its anti-neoplastic effect?
it has an anti-inflammatory and anti-carcinogenic effects.
So it has a four-pronged attack. Okay, it affects on cancer cells. Many can perioperative intravenous. This is a recent article which has come out in the journals. So nowadays they are asking all these things are also in the Osce. So it has a direct effect on the cancer cells. Mechanism is by acting on the nuclear factor kappa B or endothelial growth factor or SRG oncogene. Okay, so that is the first effect. Effect on the immune cells in our body. It has an enhancing effect on the natural killer cells and also the dominance of the tumor cells. And third, effects on angiogenesis and effect on inflammation, inhibition of inflammatory cytokines. So these are the four things that can happen. And They also have this effects by sodium channel inhibition of SRC oncogene and DNA methylation. And in life, these beneficial efforts are supported by preventing the metastatic burden also. Why preoperative acute pain control is challenging after cancer surgery? Perioperative acute pain control is more challenging in cancer patients rather than normal patients. What are the reasons? Could they have been treated for cancer pain before surgery itself? Advanced cancer surgery?
They
Yes,
have
sir.
tolerance to.
They have prior opioid analgesia, therefore post-operative opioid tolerance. Anxiety related to the diagnosis of cancer may exacerbate acute pain, and extensive surgery with an associated extensive stress response are all the reasons for challenging the management of pain. What is shown here? This is something related to a topic we discussed today, CA larynx. That is the clue I can give you. Because if it had been a video, you would have found out easily, but here you can see vocal cords in a very tight position. So it is called the frozen larynx. Okay? How does it happen? Okay. Long-term complication of oncologic treatment with CA larynx will ultimately result in frozen larynx. What is the treatment required for frozen larynx?
Tracheostomy, sir.
Patient may require tracheostomy, gastrostomy, and ultimately laryngectomy to prevent aspiration. Okay? All these things are required. Identify the tube shown here.
Laser
Very good. Laser resistant.
ETT.
What do you find here?
Double cuff.
Double balloon,
cuff.
double cuff.
So this is a laser resistant metal ET tube with double cuff. And what this cuff should be filled with?
Methylene blue or saline, sir.
Methylene blue added saline. Okay, not methylene blue as it is. You must stain the saline with methylene blue, 1 or 2 drops of methylene blue, and inject that saline. How many ml of saline will be required to fill up this balloon? Any idea? 10 ml minimum. Okay. So what are the tubes here?
Tracheostomy.
Which one is the tracheostomy? Top one, middle one, or bottom one?
Bottom.
Middle and bottom.
Bottom one is a regular tracheostomy tube. Very good. What about this and this?
They're armored, like.
Armored, yeah. This is an armored tube. Excellent. But the shape, other things. So this is what is called the laryngoflex, the flanged device from a reinforced tracheostomy tube ultra. So this is the flange, which is present here in all these things. This tube is used for intraoperative laryngectomy surgery. Okay? This is a laryngoflex tube, and this is the standard cortex tracheostomy tube. This is called the ultraflex tracheostomy tube. Okay? So, in order to facilitate the attachment of breathing circuit away from the surgical field, this extension has been given. So this is called the laryngoflex flanged tracheostomy tube. What is this tube called? This is almost similar to this. This is also used during laryngectomy, total laryngectomy. Through the tracheostomy, you can insert this tube. And I told the name also during discussion. Starts with M. Montandon or J tube used in total laryngectomy. Okay. So this is a picture to show you how you can pack the nose with a breathing tube. Okay, nasal packing with breathing tube, and this is the sponge I told you. Nasal packing sponges with breathing tube under retrieval threads. So these are all the threads that can be. So we can insert this sponging portion, which will act like a tamponade to prevent any bleeding after FESS surgery, and this tube will help the patient to breathe. Okay, so this is the picture that will be used. So these tubes are connected together so that it doesn't slip and the single tube goes into that mouth. And here the threads will help you to pull it out in case it slips down. What is shown here?
Superficial cervical.
Stellate ganglion blocks.
Stellate ganglion blocks.
Excellent, excellent. Stellate ganglion block. Whoever said that is very good. So it's a stellate ganglion block site under ultrasound guidance. The structures are sternocleidomastoid, thyroid gland, carotid artery, IJV, vertebral vein, vertebral artery, longus collis muscle, and scalenus anterior muscle. And above the longus collis in the facial space underneath the carotid artery, you have to drop the deposit the local anesthetic. So the yellow arrow represents the direction and depth of the needle. The yellow dotted line represents the lamina profunda of the fascia colli where you have to deposit. So just on the top of the muscle, the solution should be deposited. Mention few indications of stellate ganglion block.
Inadvertent intraarterial thiopentone injection, sir.
Chronic shoulder.
Nowadays, you are not using thiopentone at all. One of the older method, yes, that is one of the indications, but more commonly used by pain
Chronic
physicians.
shoulder pain.
CRPS, chronic complex regional pain syndrome of the head and upper lip, Raynaud disease, upper extremity embolism, phantom limb pain, chronic post-surgical pain are all the indications. What type of probe and needle are used for this ultrasound guided block?
High frequency.
High frequency, linear
High
probe or curved probe? Linear transducer probe, 22 to 24 gauge echo enhanced needle. What are the clinical signs of a successful block?
Syndrome.
Horner syndrome. What are the components of Horner syndrome?
Ptosis, meiosis, anhydrosis, loss of ciliospinal reflex.
Meiosis, anhydrosis, and ptosis. And some people include what is called inophthalmos, fullness of the eye also. Okay? And flushing of face and extremities, increased temperature in the arm, blurred vision, inophthalmos. All these things are the features of stellate ganglion block. What is different in this gas outlet which you have seen?
Oxygen is in
Green color.
Green color
Comes
is
from
red.
pendant.
Oxygen outlets are there and two forces are connected. Why there are two different forces? Okay, the upper green hose is for high pressure hose attached to the oxygen outlet. This is for delivering oxygen to the patient to the machine. Okay, the other one, the lower oxygen outlet, has a transparent high pressure hose. This one. Okay, this is attached to that. What is the purpose of that? Now this is the connection that is going out here, and I am showing the entire circuit that is attached to the lower
jet ventilation.
jet ventilation. Fantastic. And I have shown some markings here for some components of this jet ventilation equipment. I have marked. Are you able to see 4 lines here?
Yes, sir.
Yes, sir.
Black lines which are there. So what is this?
Oxygen
What is this?
source, pressure.
Yeah, this is the hose that is coming from the machine and attached here. Okay. And what is this?
Pressure
Pressure gauge.
Pressure gauge with a adjustable valve. And what is this? This blue color.
manual.
And this is called the toggle switch. By pressing the button on the top, you can release the oxygen or block the oxygen. And you can see a small needle here. That
Yes,
is
sir.
the one which we
Outlet.
do into the bronchoscope for estimation. Okay. So the components are this high flow jet ventilation, high pressure hose, this one, pressure gauge and regulator. This is the two. This is the toggle switch, the blue color one, and the delivery nozzle. These are the four components. What are the indications for high frequency jet ventilation or high flow jet ventilation?
So tubeless.
Severe respiratory failure, air leak syndromes like bronchopulmonary fistula, bronchopleural fistula, refractory hypoxemia, failure of conventional mechanical ventilation, respiratory distress syndrome, laryngotracheal surgery where tubeless ventilation is required. Okay, all these are the indications for that. What is blue protocol in US exam, ultrasound exam?
Bedside lung ultrasound examination.
Examination or something else for the last E? In emergency. Okay, it is bedside lung ultrasound in emergency. That is E for emergency, not examination. Okay.
Yeah, okay.
What are the 6 pathological conditions which can be made out using blue protocol?
So pneumothorax, pulmonary edema, pleural effusion.
They said 3. 3 more are there. Okay, pulmonary edema, pulmonary embolism, pneumonia, pneumothorax, COPD or asthma or pleural effusion. Okay, all the things. Describe the flow chart using lung sliding to identify the various conditions. Of course, this will be helpful to you. Just see that. So use the lung sliding. If it is present, then look for B profile, which will tell you whether it is a pulmonary edema or not. A profile, sequential venous analysis, thrombosed vein, pulmonary embolism. 3 veins, stage 3, PLAPS point, and pneumothorax or COPD. Anything, whether lung sliding is there or not, A or B profile to find out pneumonia. If lung sliding is abolished, then look for B profile, it can again be pneumonia. A profile plus lung point plus without lung point, it is need for other diagnostic modalities, which is pneumothorax. This is the flow chart that can be used. Now, which of the following ultrasound patterns in the lung is associated with acute pulmonary edema? A lines, B lines, lung sliding, and consolidation. B lines, very good, correct answer. If the patient had clear lungs, normal chest radiograph, a bedside sonogram with A lines with normal sliding, and a mildly diminished ejection fraction, which of the following should be the most likely next choice for an imaging modality? The options are CT angiogram, CT scan of the abdomen with pelvis with IV contrast, cardiac magnetic resonance imaging, ventilation perfusion scan of the chest.
CT and
CT angiogram of the chest.
Ventilation perfusion scan, sir.
Yeah, ventilation perfusion scan only. Quickly, true or false? Okay. The potency of local anesthetic depends on its pKa.
Yes, sir.
True, sir.
True. Potency is, does it depend on the pKa?
solubility.
Yeah.
Depends on lipid solubility.
Lipid solubility. It is only onset of action. Okay, it is false. I mean, potency is, sorry, it should be false. It is not dependent on the pKa. It is, it should be F. Marked it wrongly. Lignocaine has a wide therapeutic index. True or false?
All
Narrow
False.
therapeutic index.
therapeutic index.
Is the answer coming? Is it coming as true? Don't see that. No. Cardiotoxicity of lignocaine is seen at level above 10 microgram per ml.
True, sir.
15 to 30.
Cardio 15, 20.
30 mics.
It's true. Yeah, 2.5 to 3.5 neurotoxicity, cardiotoxicity more than 10 micrograms. Okay. Lignocaine used intraoperatively can result in faster extubation. True or false?
False.
False.
False. It will delay the extubation because patient will tolerate the tube.
Tube tolerance.
The contact sensitive half-life after 3-day infusion of lignocaine is 20 to 40 minutes.
False.
True. So 3 days infusion, it is 20 to 40 minutes. Okay. In pain pathways, second order neurons are stimulated by primary A, beta, and C fibers.
A delta.
A delta only.
Delta.
Then it is
Yes.
false. Right. The NMDA receptor is activated by magnesium ions to inhibit pain signaling. True or false?
It's inactivated by magnesium.
Antagonistic. Yes, then antagonism only will inhibit the pain. It is activated means it is stimulated. Yes, it's false. NMDA receptors involved in pain pathways are located on postsynaptic membrane in the ventral horn of the spinal cord.
False. Dorsal horn.
Dorsal horn, very good. Magnesium has an established role in chronic pain.
True, sir.
Magnesium is not one of the drugs. False again. It has a short action, so it is not useful in chronic pain. Wind up is a phenomena involving reduced descending inhibitory signaling leading to pain hypersensitivity.
It increases. Wind up.
It is a continuous depolarization. So it increases.
True, sir. True, sir.
False.
Decreases the sense.
It has an inhibitory. It doesn't have inhibitory. It is stimulating. It causes more pain. Wind up phenomenon means there's a continuous depolarization. So continuous depolarization means there's a continuous transmission. So pain will be perceived more. Okay. Wind up results from sustained depolarization of the secondary neuron due to high frequency stimulation by C fibers. That will result in increase in pain. So this leads to removal of magnesium plug from the NMDA receptors if magnesium is being used for pain. That will lead to the sensitivity. Fentanyl has a contact sensitive half time that rises rapidly after just 1 hour of infusion to 260 minutes.
False.
False. 50% decrement time displayed in target controlled infusion pump is equal to the contact sensitive half time. Correct or true or false? That's 50% decrease in the plasma level displayed in the control pump is equal to the contact sensitive half time.
False, sir. It is after
It
stopping
becomes
the infusion.
after it is displayed in the TCI pump that the 50% has decreased. That means it has reached the contact sensitive half time. Okay. Remifentanil has a CST of 6 minutes and rapidly metabolized by plasma esterases.
True, sir.
2 is only part of this. But this answer, is it true?
Yes. 1 to 2
CST
minutes
of
of
remifentanil is one drug which does not have a different contact sensitive of life, irrespective of the duration of infusion. For all duration of infusion, the CST of remifentanil is only 3.8 minutes. Please remember that. So this half is wrong. So it is false, even though this half is right. Alfentanil is a pure mu receptor opioid agonist that has 1/4 the potency of fentanyl, a brief duration of action, and readily titratable, has a pKa of 8.
False, sir. It is highly potent in fentanyl.
Highly potent, and that is not the reason. The answer is false is right, but the pKa is only 6.5. pKa is not 8 for alfentanil. Okay. Then titrating down propofol and alfentanil combination for TIVA at the end of surgery, which one should be reduced first? Propofol should be reduced first, correct or wrong? When you are using propofol and alfentanil, which one should be titrated or slowed down first?
Oh, sir, we are reducing the hypnotic doses of propofol. So, true.
Again, false, because alfentanil has got a shorter half-life. So you can, you have to reduce, longer half-life, contact sensitive half-life. So first you reduce the alfentanil, then propofol. Okay? Capnography is less useful in non-intubated patients compared to intubated patients because the accuracy is significantly reduced. Is it true or false?
True, sir.
Capnography is now recommended for non-intubated patients also because it gives the exact respiratory rate and then whether the CO2 elimination is taking place normally or not. So it is definitely recommended. It is not reduced. Accuracy is very good. The Beer-Lambert law describes the relationship of components of gas mixtures using mass spectroscopy. True or false?
Not the components, sir. The concentration and the
Volume.
First, tell me whether it is true or false.
False.
False, sir.
False. But the explanation is not correct because the Beer-Lambert law uses the relationship of logarithmic values of these square components using infrared spectroscopy, not mass spectroscopy. Okay, you use infrared lights, isn't it? Both for oxygen and other estimation, it uses infrared light of various wavelengths. Okay, so that uses the logarithmic relationship of the components of the gas mixture using infrared spectrum. So that is the answer. It is not mass spectrometry, so the answer is false. The AAGBI recommends mandatory use of capnography for all patients with endotracheal tubes or supraglottic airways, but to consider capnography for deep sedation. Is it right or wrong? Or true or false? Is again false because nowadays it has become mandatory to use capnography in deep sedation procedures like endoscopic procedures where you use sedation. You have to use capnography to find out whether the patient is going in for respiratory failure, some stage of deep sedation. So it has become mandatory. Partial airway obstruction will present with a higher PET VTCO2 on the capnographic waveform. True or false? Partial airway obstruction, just logical thinking.
True, sir. There will be decrease in the ventilation and increasing in the.
It will not come out. Partial obstruction will the carbon dioxide come out. So it is false. It will show a falsely low VTCO2. Partial airway obstruction will show a fallaciously low VTCO2. Whereas there will be accumulation, but because that CO2 cannot come out, it will show a falsely low, not a high VTCO2. Non-intubated patients, mainstream capnography gives a more accurate reading of PaO2 compared to side stream.
False.
This is true because mainstream will be very close to the patient's nose. You are not intubating the patient. You don't have a gadget in the end. Yeah. So whatever comes out through the nose and mouth, it will be picked up and the sensor is very close to the patient. So mainstream capnography is more ideal for non-intubated patients compared to intubated patients. Okay. What is a neurolytic block? By taking how much time?
Even in case of chronic pain,
Neurolytic block. What is the definition?
Causing neurolysis with alcohol, sir.
Targeted destruction of a nerve or a nerve plexus is called neurolytic block. Targeted destruction. We destroy the nerve. We are not just blocking it temporarily. We destroy the nerve. So a targeted destruction of nerve or nerve plexus is called a neurolytic block. What is neuroablation? Is another terminology. So neuroablation describes the physical interruption of pain chemically, thermally, or surgically. Okay, so you can do it by any of these methods. What happens when the nerve or nerves are subjected to neurolysis?
They'll not be conducting the signal.
What are the changes that happen in the nerve? So all neurolytic techniques cause what is called Wallerian degeneration of the nerve axon distal to the lesion where you apply. Okay. What are the newer, safer methods of neuroablation compared to the old method of using your chemicals like alcohol or phenol? What are the newer and safer methods?
Radio frequency, sir.
The ablation.
Radio frequency ablation, very good. Number one. Anything else? Of course, cryoablation and surgical neurectomy are newer and safer modalities. Name two commonly used chemicals, agents used for neurolysis.
Alcohol.
phenol.
Alcohol, what percentage? Alcohol and phenol are correct, but you must tell the percentage. 50 to 100% alcohol or 5 to 15% phenol are commonly used chemical agents. What is their mode of action? Is there any difference in the mode of action of these two drugs? How do they cause neurolysis? How does alcohol cause? How does phenol cause? Both same mechanism or different mechanism? The mechanism of action of alcoholic neurolysis is oxonal and Schwann cell destruction from phospholipid extraction in the cell membrane and lipoprotein precipitation. Whereas in phenol, it causes damage to protein coagulation and degeneration. It's a small difference in that. How is radiofrequency ablation more safer than chemical neurolysis?
Because the anatomy is preserved in radiofrequency ablation.
Anatomy is preferred. It's more selective. Okay? Conventional radiofrequency generates a current with an oscillating frequency, producing heat over 60 degrees centigrade that causes circumscript lesions, which will selectively prevent the nerve lesioning. I mean, it will be more selective. What is cooled RFA? Here we say the heat produced is 60 degrees. So what is cooled RFA and what is their advantage over conventional RFA? Water will be cooled RFA gives active cooling by continuous flow of water that prevents the current from reaching high temperatures experienced in conventional ablation. So this allows for patient will not feel the heat. That is the advantage of cooled RFA. This allows higher temperatures and more spherical and larger lesions. Then we stop that with that and see you next week. Okay.
Yes, sir.
Yes, sir.
Thank you so much.
Thank you, sir.
Yes, sir.
Thank you.
So you can send me a feedback or whether this sort of different type of case scenarios are preferred, or you want to have the conventional regular discussion which we have gone through several times during our earlier classes. Whatever you want to let me know, we will decide accordingly. Okay.
Yes, sir.
Yes, sir.